I want to welcome the commissioners and the members of the public. This meeting is a hybrid commission meeting. There are several commissioners here in room 100, and the rest of the commissioners are participating via Zoom. Given this is a hybrid meeting, we will apply our additional ground rules. I'll begin with the roll call of commissioners. During the meeting, I'll ask that people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's talking and will have the same knowledge as the folks who are here in room 100. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask commissioners and others to mute their phones when they're not speaking. For this meeting and in future remote-only meetings, we will post documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. I'll now call the roll. Dr. Akintade? He said he was not going to be here.
He may be a last. He's a last minute.
Okay. Dr. Mandari?
Yeah.
Commissioner Boyer? Oh, she's a no. Commissioner Boyle?
Here.
All right. Commissioner Brumbat?
Here.
Commissioner Cheatham? She was a no. I apologize. I see Commissioner Dorton. Commissioner Jensen?
Pleased to be here.
Good afternoon. Commissioner Metz?
Yes, sir.
I can see Commissioner O'Connor is here. Commissioner O'Grady?
Here.
Commissioner Wang?
Here.
And Commissioner Wood.
Here.
Good afternoon, everybody. This is my first effort at chairing the meeting. So I wanted to say, kicking it off, one of the things that I really value about this commission is the mix of in the healthcare industry. We have providers who represent hospitals, doctors, nurses. We have members who are consumers. We have folks with IT expertise. We have folks who work for payers, as I do. And we collectively deal with large problems in the area that no one side of the industry or one side of is going to produce the one solution to our problems. And we can come here and we can talk about them and we can think of solutions together that will work collectively for everyone. And I want to encourage all the commissioners for that reason to do two things. One, we do a good job of participating. Keep that up. Ask your questions. Feel free, if you don't think you know something, to speak up and make sure you understand it before we act on it and that we're acting in the best interest of the public. And two, if you're like me, I listen very hard for the aspects, the perspectives in the industry that I don't see in my daily job. So I can tell you a lot about healthcare financing and funding. I don't know as much about healthcare quality and the imperatives of being a doctor and what that looks like. So I listen very hard when other commissioners speak with a perspective that's not something I'd understand. And I encourage you to do the same. And with that, I will do my very best to make sure everybody is able to get their questions out and the meetings run smoothly. In terms of naming a vice chair, I've had a couple of folks express some interest, and I just wanted to make sure that anybody else let me know. I'll pick a vice chair to run the meetings when I'm not here shortly before the next meeting, I expect. But if anybody else is interested, just let me know and give me a call. Everybody who has asked and everybody who's a commissioner will certainly be qualified and capable of doing the job. So we'll pick one for the next meeting. With that, I think our first item is approval of the minutes. Included in your packets are copies of the minutes from the April 21, 2022 public meeting of the commissioner that took place in person and by video conference. I will entertain a motion to approve the minutes of the April 21, 2022 commission meeting. Do I have a motion?
So moved.
Just one correction. I was present telephonically, but it's not recorded here. I had difficulty making the connection.
Okay. So
I guess I need to speak to Lamont, maybe. I don't know.
We can add, how about Commissioner Dorton? Can you make a friendly amendment to add Commissioner O'Connor to the minutes?
Make a motion to amend the minutes to include Dr. Dr. O'Connor is participating in the last meeting.
Thank you. And I think we had a second.
I'll second.
Me.
I saw Dr. Bandari. Thank you, Commissioner Bandari. Seconded. All in favor?
Aye.
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 Are there any opposed? Great. The moved minutes have been approved. Agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? If not, does the executive director have any updates?
Thank you, Chairman Sargent. First off, on behalf of the staff, we want to congratulate you on your appointment as Chair of the Healthcare Commission. Speaking for the staff, we look forward to working with you and all of the commissioners moving forward. The commission staff views the commission as setting the agenda for our work, and that has continued throughout the time I've been executive director, and we continue to respond to the needs of the commission as chairs and commissioners change, but nonetheless, the commission itself sets the agenda. I did want to bring commissioners up to date. Last month, you heard a update from Tracy DeShields on all of the legislative proposals, actions that required action on our part. It's a little too early to talk about many of them, but several are already underway. One of the studies required under our authority to address cost of potentially new mandates has already gone out to bid. That is the study of the impact of mandated coverage for home health kits for sexually transmitted diseases. The other two potential mandates, one on an expansion in vitro fertilization coverage, and the second on coverage for or equivalent coverage for physical therapy benefits, are in the development phase but are not out on the street. Another small effort on which we are responding to because of a request from the legislature refers to the study on interstate telehealth. We have submitted a small proposal that should be out shortly if it hasn't been released. It's already out. And we look forward to identifying a firm that can assist us in judging both the impact of interstate compacts for furthering interstate telehealth, the impacts of medical malpractice insurance coverage on telehealth services, and potential impacts on carriers' network participation as due to participation of out-of-state providers in the delivery of telehealth services. This was a issue that was debated to some degree, but the legislative leadership felt there needed to be more information on post end of the pandemic, what were going to be common practices, best practices moving forward. We'll look forward to getting those responses. All of those reports are due by December 2022, so we have a relatively short time frame to turn this around. Another very important bill was the two-sided incentive arrangements legislation. The commission has a important role in monitoring the rollout of those programs. And we have begun internally to communicate on what sort of information would be needed from carriers to monitor the performance under these new incentive arrangements. Keep in mind that many of these arrangements have been possible in other states, but until Maryland law was changed, carriers were very much limited in their ability to offer them. The legislature approved of those arrangements, but felt that there was additional monitoring that was required, and that responsibility was given to the commission. We think that this type of activity falls very much in line with commissioners' interest in capturing information on non-claimed-based reimbursement more broadly. So we're thinking about this in a way that can encompass both the responsibilities under House Bill 1148, as well as a broader interest in how best to gather information on these new non-claim-based reimbursement systems going forward. The other piece of information post-session, we did get an inquiry from the Secretary's office on our willingness to participate and perhaps take a leadership role in a work group on developing a public awareness campaign on preventing workplace violence in healthcare settings. The turnaround time is relatively quickly. I've talked briefly to the chair about that and expressed our willingness to help and offered a few ideas to the health secretary on ways we could be supportive, perhaps taking a leadership role in that work group. We're waiting for them to respond on their preferences there. The other broad area I wanted to just talk about generally, and I'll note that in the room with us today is Gene Ransom, CEO of Mcdb, who will speak on an initiative later. But one of the very important bills that passed in the session this year was 1127, which broadened the authority of CRISP to establish a public health data utility. The Healthcare Commission has been working very ambitiously in the state to really build out the definition of what a health data utility is, which it is really what I would call the next generation of health information exchange. It involves, engages the exchange in combining and using data across a wide range of information flows, both clinical and administration sources to support clinical decision-making and public health. A key function is easing the ability of providing clinical information back to caregivers in a simplified and more streamlined way. And most importantly, also to support public health projects, particularly the key role of public health in terms of surveillance and prediction, as well as what's recognized now as new roles for public health in addressing health equity, in furthering the development of new care models that can really achieve some of the broad goals here in Maryland that we seek to meet under the total cost of care model. David Sharp's team has taken a leadership role in that at the recent state meeting. I spoke on the our concept of the health data utility. We are working with the Organization of Health Information Exchanges nationally, Civitas, Health Networks for Health, and together we hope to build out a common concept of what a HDU framework would look like, which will guide our development here in the state, as well as help other states evolve this concept moving forward. To that end, we've submitted a couple of abstracts to national organizations, one being Civitas's national meeting later this summer, as well as an organization that we participate with, National Association of Health Data Organizations, which we've submitted a proposal on HDUs as well. We think this is a very important concept and has been demonstrated. The utility of the HIE has been further validated throughout the pandemic. The department has really signaled its commitment in allocating $5 million to building out capabilities for nursing homes to provide information to the HIE that can be shared more broadly. And we think the Healthcare Commission, as having key authority for oversight of the HIE in the state, the organization responsible for developing regulations governing the operation of not only CRISP, but all 11 other HIEs that operate in Maryland, that we have a central role in furthering this health information exchange, and really look forward taking this on. We think Maryland has been a leader, and I think the commitment of the commission over the last 4 or 5 years has been continued for the commission itself to play a leading role, not in operating an HIE, but setting the framework in which they operate. So we're excited about that. Lastly, as time to time, you know that I highlight staff that are doing what I think are important research pieces and public awareness papers. I wanted to note that Melanie Cavalier will be presenting at Academy Health next month. Academy Health is the leading health services research organization in the country, and their annual meeting is the most important national meeting that Academy Health hosts every year. She'll be talking about using health IT to improve patient-centered care, and we'll look forward to providing you a copy of that presentation when it's been approved by Academy Health for release prior to the meeting. That concludes my update. I'll end with what I said at the start. Very excited to work with the chair moving forward and support his directions and priorities as they align with our broader objectives.
Thank you. I will do my best to carry out this role with the aplomb and gravitas of my predecessor, Dr. Pollack, who will be greatly missed, I think, for his input. So thanks for the updates. Before we consider action items today, or I guess I should say, did anybody have any questions for Ben on the updates? Sorry about that. Look, we don't. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves in any action item, they should inform the chair. For commissioners participating remotely who desire to recuse, they should remain silent, turn off their cameras, and mute their phones. And then commissioners who are present in room 100 or who are recused should move to the small conference room during the discussion of any recused items. That brings us to agenda item number 3, the certificate confirmation of emergency certificate in need for the University of Maryland Capital Region Medical Center. The University of Maryland Capital Region Medical Center has requested an emergency CON to add 16 medical surgical beds. The proposed unit would be located on the first floor of the hospital in space that is designed to function as an observation unit, but is currently being used for outpatient clinic space. The clinics will be relocated to modular units located on the hospital parking lot. These modular units were placed into operation as intensive care space in 2020 at Prince George's Hospital Center in Cheverly through an emergency CON and operated in Cheverly until June 2021, when Prince George's Hospital Center was replaced by Capital Region Medical Center in Largo. The additional beds are intended to assure that the hospital has additional inpatient bed capacity to better handle potential COVID-19 related surges in bed demand over the next year. Winnie Hawk, CON Chief of the Health Facilities Planning and Development, will brief the commission on this emergency CON request. Winnie, the floor is yours.
Good afternoon, Mr. Chairman and Commissioners. Winnie Hawk here. Before you for confirmation.
I apologize.
No worries. It's spelled very oddly. Before you for confirmation is an emergency certificate of need. This was issued on May 12th. The project authorizes Dimensions Health Corporation, doing business as University of Maryland Capital Region Medical Center, to add bed capacity on a temporary basis. They are going to convert 16 existing observation beds of a 20 observation bed unit currently on the first level of the hospital to med-surg beds. The project, the estimated cost of the project is $100,000, and the project timeline is approximately 60 days. They're estimating that it should be operational by July 1st. You may recall that previously the commission has approved a certificate of ECON for a 16-bed addition to University of Maryland Prince George's Hospital Center for a 16-bed MSGA beds into modular units back in 2020. And then when the hospital was replaced in 2021, those beds, the hospital was then moved to, I'm sorry, then Prince George's Hospital Center became University of Maryland Capital Region Medical Center. So you previously approved these beds. And I would just urge that you confirm the ECON today. I would recommend approval. And do you have any questions?
Why don't we start with, well, why don't we start with a motion and then
Oh,
questions? How's that? So can I start with a motion to approve the certificate of need, confirmation of emergency certificate of need, University of Maryland Capital Region Medical Center, addition of 16 medical surgical beds.
So moved. O'Grady.
Thank you, Commissioner O'Grady. And a second from, was that Commissioner? Boyle? Oh, Commissioner Boyle. Thank you. With that, are there any questions? Commissioner Doherty?
This is
Yeah,
Commissioner
Winnie,
Bhandari.
just
I have a
quick one.
question. Now hospital has moved to a new facility, and my question is why they need to change this observation bed to MSGA, although they have many more beds. Why don't they leave as observation? And this is a big hospital, big facility. We all saw that. Do they really need to convert these observation, or they have extra bed in other floor where they can use also?
my understanding is that the observation beds are currently being used as medical clinic, beds. And they're going to move the medical clinic to the modular units, which are in the parking lot. And they're only going to retain use of the observation beds. The medical clinic beds were they were using only 5 of the observation unit beds as observation beds, and the other 15 were medical clinic beds. So they're retaining 4 as observation beds. And if there's overflow, the overflow will be utilizing the pre-op area. So the current use of the space is not fully observation space.
I understand that, but what I was trying to say, there may be additional bed on other floors also, rather than moving this clinic to the modular.
Sorry.
I'm not sure I
The
understand.
audio, I'm afraid, I'm sorry, Commissioner Bhandari, the audio is not very loud. Could you say that
I
again?
couldn't, yeah.
What I'm trying to say is, rather than moving these clinic to the modular, because it's a new hospital, new building, I'm sure they have extra space for those 16 MSGA bed in other location, rather than moving, these clinics to the modular unit and converting these to MSGA. Or they don't have extra space. That's what my question is.
We actually looked at the occupancy rate for the first quarter of 2022, and their average occupancy was 84%. So the bed occupancy was higher than the target occupancy. So they really do need these extra beds.
Thank you.
Commissioner Doherty?
Winnie, just so I understand, this is a temporary 1-year authority, right? So if the next step was they wanted to permanentize these additional beds, the organization would have to come back, request that they be permanent and not just during this 1-year period.
That's correct. This is only good until April of 2023.
Thank you.
Hi, Winnie. Thank
Does
you.
that, Jared, just one quick question.
Sure.
Does that mean they have to, if they wanted to do something, it requires a full CON?
I believe so. They would
I
have-
didn't know how things changed or if they did.
Thank you. This bed request is for, I assume, COVID overflow patients.
Correct.
Do we have accurate numbers on the actual number of admissions for COVID now, right now? To my knowledge, COVID admissions are dropping pretty drastically. So why are they asking?
I think, what is represented is they're anticipating any potential surge in the fall. I don't have the numbers now. I can certainly look into that.
Are there any other questions?
Are there representatives?
Oh, I'm sorry, there are representatives here from Capital Region. Counsel for the hospital, Tom Dame, is available, as well as the Chief Operating Officer, Min Godwin.
Just curious, just.
I had one question for you. It's really not about the CON, but this recommendation comes us from the Office of Healthcare Quality, and there is a planning process underway as to what facilities are likely to need to handle a surge. Isn't there? Like, there's a broader discussion going on. This isn't just one hospital on its own.
I'm sorry, there was well, the secretary extended in all of the hospital CONs in April, and this, I'm sorry.
So Winnie is correct that the secretary asked the Maryland Healthcare Commission to extend all emergency CONs. The commission, looking at it, having some additional information, knew that some of the emergency CONs issued in March and April of 2020 had never been activated. The commission decided to ask the staff to make inquiries on the status of those CONs with the instruction that if ECONs had never been activated, those CONs, there was no need for them to be renewed. At the meeting last month, Paul Parker brought you the list of ECONs that had been activated, as well as a listing of those that had not. He also stated that after you extended those that were active, and we also indicated and informed the hospitals that those that had not had their ECONs approved could apply to extend those for good cause. I don't believe we've received any requests to extend non-activated ECONs up to this point. There's a few days left in that window, so it could still happen, but I don't have any indication that there are any. Secondarily, Paul is working with a multi-agency team to look long-term at the solution of surge hospitals or surge capacity, with the goal of identifying perhaps up to a half dozen, perhaps a few more hospitals that would have, in the case of future pandemic surges, the capability to stand up to 30 bed units within those hospitals. That initiative is independent of these ECON activities, and I think longer term, that may be the way forward. Keep in mind what Winnie is asking you is to extend this the request today through April of 2023. It is possible that a future health secretary could ask extend it further, but my expectation is that the next phase will be a much more organized approach with a fewer number of hospitals responding to the surge, ideally geographically distributed across the state, so that folks from the Western Shore or Eastern Maryland potentially would not have to go to some of the alternative care sites at either Tacoma Park or Laurel, should they need that care. So that's where things stand. I don't think this is contradicting anything that's on the long-term, longer-term project, but that's a work in progress at this point.
Thank you. I don't think commissioners have any questions. If not, I will call the question. All in favor of approving the requested confirmation of emergency certificate of need?
Aye.
Are there any opposed? Great. Motion passes. Thank you very much.
Mr. Chair, this is Tom Dame, Counsel for University of Maryland Capital Region Health. I just want to say quickly, thank you to the staff and to the commissioners for their prompt and careful review of this matter.
Thank you, sir. Okay, we'll move on to agenda item number 4. Change and approve certificate of need for Encompass Health Rehabilitation Hospital of Southern Maryland. There's a request on this month's agenda for a project change after certificate of need approval by Encompass Southern Maryland for its project to establish a 60-bed special rehabilitation hospital in Bowie. This is the second project change request submitted by Encompass Southern Maryland, which was previously granted a budget increase of $6 million in 2021. The applicant is now asking for an additional increase of $6.7 million due to increased site preparation costs, design modifications, and construction cost inflation. Maura Lawson, Program Manager in the Center for Healthcare Facilities Planning and Development, will present the staff recommendation. Maura?
Thank you, Chairman Sargent, and good afternoon, Commissioners. As you just heard, the request before the Commission today is for a second modification of an existing certificate of need to Encompass Health Rehabilitation Hospital of Southern Maryland to increase total project costs for the establishment of a 60-bed rehabilitation hospital in Bowie. Encompass, formerly known as Health South Corporation, is a Delaware limited liability company and a subsidiary of Encompass Health Corporation, a publicly traded proprietary corporation. Encompass Health has a nationwide network of inpatient rehabilitation hospitals, home health agencies, and hospice agencies. On May 1st, 2020, the Commission approved a certificate of need for the construction and establishment of the hospital at a budget of $39,819,094. On March 18th, 2021, Encompass returned to the Commission for a change after certificate of need approval to increase the budget to $45,982,206. The reasons cited for the increase at the time were inflation, a government mandated design change, and an underestimate of equipment costs. Encompass now requests an increase in project costs to $52,683,586, which will be paid for with cash. The request also includes a small design modification, which will decrease the square footage of the facility by just over around 3%. Encompass cites the following reasons for the increase in costs: inflation, permitting delays, design changes, and unanticipated site preparation costs due to unsuitable soil conditions and the unanticipated need to relocate a gas line. This request requires Commission action because it would incur capital cost increases that exceed the approved capital cost inflated by an amount determined by applying the building cost index that's published by the Healthcare Cost Review from the application submission date to the date of filing the request for approval of project change. The staff assessed the impact of this change on the financial performance of the facility. And as in the 2021 approved change, Encompass projects that it will generate positive net income in the second year of operation. While the increase in total project cost is significant, Encompass states that it will still fund the project with cash. Commission staff does not believe that the increased cost of the project will affect the overall viability of the project in the long term. There are no material changes in the location, capacity, or nature of the project. Therefore, staff concludes that this requested modification does not change the Commission's 2020 findings concerning the need for and positive impact of the project. The project's impact on existing providers remains consistent with the Commission's prior findings in the original CON. It is not expected that this increase will result in higher Medicare or Medicaid or costs to the Medicare or Medicaid programs. And for this reason, or for these reasons, staff recommends that the Commission approve Encompass Health Rehabilitation Hospital of Southern Maryland's request for a project change after certificate of need, including the original conditions that were issued with the CON. Attending on the phone today for Encompass are Susan Lyerly, staff attorney, state regulatory and compliance at Encompass Health, and Ella Aiken, counsel for Encompass. Thank you.
Start with a motion. Can I get a motion to approve the change in certificate of need for Encompass Health Rehabilitation Hospital, Southern Maryland?
So
Commissioner Mindari.
I heard Commissioner O'Connor first. Can I get a second?
Mindari.
Bandari has his hand up for a second. Great. Do any commissioners have questions or discussion? I have a question that's, I noticed, like, we're talking about a 1.8% increase, inflation increase would be the cap to require approval. And I was hearing on the news that inflation is running at 8% right now. Is that an entirely realistic number in terms of measuring inflation on projects?
We have a formula that I believe is regulated that we use particular numbers for this. This is where the numbers are when you apply the formula we have to use. And
I'm sorry.
I agree. I think it's.
And just to make sure, I think I understand it. What I'm talking about is if they increase up to, if they get an increase up to 1.8% on account of inflation, they don't have to come back to us. But if it goes over 1.8, then they would have to come back and seek a modification. If there are no other questions, or comments, I'll call the question. Great. All in favor of the approval of the change in certificate of need for Encompass Health Rehabilitation Hospital, Southern Maryland, say aye.
Aye.
Are there any opposed? Great, the motion passes. Thank you very much.
Commissioner, this is Ella Aiken, counsel to Encompass Hospital. I just wanted to quickly share on behalf of Encompass our thanks to the commissioners and the commission staff for the review of this matter, and that Encompass looks forward to opening its facility next year and begin providing these services in Maryland Southern region. So thank you.
Thank you, Ms. Aiken. Turning to agenda item number 5, the annual assessment of the state health plan, priorities and timeline for review and revision of state health plan regulations. The state health plan establishes standards for health facility project reviews, including projects requiring certificate of need approval and certain other types of facility project or program reviews. Maryland law requires that MHCC annually assess the state health plan to determine the need for revision and updating of the plan's regulations and to establish priorities for updating those regulations. Paul Parker will brief the commission on the current state of the state health plan and priorities for updating the plan regulations. Paul, you have the floor.
Thank you, Chairman Sargent, members of the commission. Every spring for the last few years, we have presented an update on state health plan development and redevelopment. The law was changed a few years ago to formalize that requirement. So that's what we're here to do today. Next slide, please. So the state of the state health plan, well, the requirement here is highlighted. This is a list of summarizing what the law, our commission law says about the state health plan. And there in the middle is the requirement that we're addressing today, the annual assessment, determining the chapters that need review and revision and establishing priorities and timelines. Next slide. This is the state of the state health plan. And as you can see, we have 15 chapters of regulation currently in the state health plan. 9 of those have actually been updated within the last 10 years. 6 of the 9 have actually been either updated or in one case newly created within the last 5 years. So we actually have been making steady, if not spectacular, progress in updating these. And I'll relate kind of the priorities that are reflected here in this slide in the next few slides. Next one, please. So here is the frequency at which these state health plan chapters of regulation come into play. This is looking at about 11 years of certificate of need project reviews. It does not include exemptions, so I'll state that up front. And we do have a number of projects that come through as exemptions from CON review, the conversions of hospitals to freestanding medical facilities. We've had 5 of those in the last few years, for example, but those are all outside of the process of certificate of need review, their exemption reviews. So this is looking at how frequently we use these for CONs. If we included the exemption reviews, the pattern wouldn't be that much different. So among our higher frequency, the three that are the highest frequency, general surgical services, comprehensive care facility services, and general hospice services, all of those have been updated within the last 10 years, and for general surgical services and comprehensive care facility services within the last 5 years. There is an incorrect date on the comprehensive care facility. That was actually updated in 2019 rather than 2021, but still within the last 5 years. When you look at the more kind of medium frequency reviews, we have general hospital services projects, and that is a set of regulations that has now become more than 10 years old, but that is actually in progress. We convened a work group last year to update this plan, and we expect to bring those regulations in for review in the latter half of this calendar year. We do have one set of regulations here, the alcoholism and drug abuse ICF treatment services, which is, relatively frequent reviews. We have averaged about 1 per year, and that is still needing an update. We'll see later in this presentation that we have identified that as a high priority for updating. It's still a quite serviceable plan in many respects, but we had success, I would call it success, in modifying the law for those types of facilities. We now let those types of facilities expand after they've been initially established through a CON. They're allowed to expand bed capacity without a CON. So that is one change in the law that we supported, but it also has made this plan obsolete in some respects, because we do have a bed need methodology that gets applied to the ICFs that are primarily private pay. Home health agency services, another medium frequency. We've had an update within the last 5 years. And then on these lower frequencies, even there, other than residential treatment center services, those have been relatively recent updates. Just last year for psychiatric hospital services, within 10 years for rehabilitation hospitals. Next slide, please. So this is giving you a snapshot this month of what's coming in the future. The CON applications that we've docketed for review. In some cases, we've received them recently and they have not been docketed. And then the valid letters of intent. I'm sorry, the columns have not aligned on this slide, but those valid letters of intent means that they've been received within the last year. So they have a shelf life of a year in which you can submit a CON application. The asterisk on the 2 general hospital services CON applications, we managed to lose the footnote for that asterisk, but what I was footnoting there is that both of these applications are inactive at this time. They are, without going into a lot of detail, they're hospitals that they're hospital applications that ran into problems with respect to the payment model and the support of HSCRC. So that's one reason why they have not proceeded. And in another case, there was a rather tortured history that I won't go into. One of those hospital applications, we do expect that to be updated and to come back into review later this year. The other ones we're uncertain about. Here again, I think we're in pretty good shape as far as the near term because the home health agencies, the organ transplantation, general surgical services, the applications that we have, those are fairly recent updates to our plan chapters. Again, it's the ICF treatment services where we have 2 applications where we are working with an older set of regulations. Next slide. So top priority, because we updated 2 of our high priorities last year, general surgical services and psych. General hospital services has now risen to the top of the list as far as an acute care chapter that needs to be updated. And as I said, that is in progress now. The next slide, please. And then our other high priorities, as you would expect, we've moved the ICF services into a high priority category, and we're hoping to get something started on that later this year. We have not initiated a formal update process with a work group yet. General hospice services, not that old, but we believe there are clearly some improvements that can be made in that chapter of regulation. We need to do that. As I note here, we are looking for changes in those regulations that would allow some opening up of areas where there is only one choice of a hospice provider. Actually, about half of our jurisdictions in the state are in that situation. There's only one authorized hospice in the jurisdiction. And home health agency services, again, not too old. We've had experience with a review cycle under this new plan, and we're currently in process with another review cycle for this plan. And that experience has indicated to us that there are some tweaks that we can make to that plan to streamline it and get these reviews completed more quickly. So that's why I've proposed that that be considered a high priority. Next slide, please. So in our medium priorities, residential treatment center services, this is a very low frequency service. So we don't see applications very often. But one of the reasons why I've kind of elevated this within this medium priority group is because we've seen a fairly steady decline in the number of RTC centers in the state and corresponding decline in bed capacity. And we certainly heard that a need for certain types of residential treatment center programming or some of the more difficult adolescents who are having a hard time getting placed now and are sometimes backing up in psychiatric hospitals. This is something that we definitely want to try to move up for reconsideration as soon as possible. What we have in place now, 2021, we finally updated the last chapter of regulation, which took the form of treating 2 different types of facilities within one chapter of regulation. That was something that was done in past years, which is not a good practice in our view. So we've tried to disentangle those types of chapters of regulation in the state health plan as we've updated plans. So we updated the psychiatric hospital services standards. The RTC standards were in the same chapter of regulation. So what we have in place now, and that's why you have that date of 1997, 2021. Technically, these standards were updated in 2021, but we didn't really update them. They just now have their own distinct chapter of the state health plan that only addresses RTC services. So they still need updating. The freestanding medical facility services, that was a brand new chapter first established in 2017. And so far, it has only been used in consideration of conversions of hospitals to freestanding medical facilities. As I mentioned earlier, we've had 5 of those. And they are not actually certificate of need reviews. The law allows those to be reviewed as exemptions from CON, although the law also specifies quite a few requirements that makes those particular types of exemptions fairly rigorous in terms of certain requirements that have to be met. We have not had any CON applications to create what I would call a satellite freestanding medical facility. So a hospital is just putting out another emergency center node somewhere in its service area. Those were created prior to the effective date of CON regulation on a pilot basis. But since CON regulation became applicable to these types of facilities, we have not seen that. So I don't know if that, not sure exactly what that means. I think it means that we're configured in Maryland in a way that doesn't really lend itself necessarily to a lot of development of that type. And then rehab hospital services is now getting older, and I think it's worthwhile to consider that a medium priority for the future. Next slide. We have the next slide. Yeah. So the lower priorities here, neonatal intensive care services, that has not been updated recently, but the core of that is really a set of perinatal system standards that are actually a product of the Maryland Department of Health. Those get periodically updated. We're currently using a 2019 edition. The plan allows us to essentially consider those updates as the applicable standards in this review. It would be a fairly easy thing to update. But again, we've had to, I think, 2 of these in 20 years. The hospitals that would be appropriate for development of new neonatal intensive care services aren't in existence anymore. We've approved NICUs for all the larger perinatal programs in the state. We do anticipate having a CON application later this year from a hospital that had a NICU but actually lost its designation by MIMS as a perinatal referral center. Obstetric services, been around for 20 years and never used once, and that was shortly after they were developed a long time ago. Don't see those coming in, but that is an old chapter that definitely should be updated soon. And then organ transplant services, cardiac surgery, PCI, relatively new, low frequency areas. Chronic hospital services, similar to RTC in that it is a remnant that's left over after we updated the nursing home chapter. Those were tucked away inside that chapter, same chapter. So now they have a chapter onto themselves, but we haven't had a project. Certainly on the last 11 years, and I'm pretty sure we haven't had one even before that. So this is it's not an urgent priority. Next slide, please. So our timeline, as I said, in FY 2023, which will begin July 1, we do anticipate updating the hospital services chapter and the general hospice services chapter, both high priorities, of course. And then in FY 2024, we would anticipate dealing with the other 2 high priority areas, home health agency services, alcoholism and drug abuse, ICF services. As I mentioned, hospital services, we actually convened a work group last year, so they're going to be completing their review and input to us soon. General hospice services, we have done the work necessary for convening a work group. We've had a lot of informal discussions with hospice providers. So that work group is going to be convened, I would say, within the next 30 to 60 days, and we'll begin the formal process of updating that chapter. And then our medium priorities, I'm outlining, kind of the obvious next steps as far as a timeline for getting to those updates. Next slide, please. And this is just a final slide about procedural regulations, which we don't really consider them to be part of the state health plan because the state health plan chapters are specific project review standards and policies that apply to specific types of healthcare facility projects. These procedural regulations lay out our procedures for conducting certificate of need reviews and other types of reviews. And actually, because we've created some other categories of project review in recent years, that's one of the main things that will be updated as part of these procedural regulations. So in the area of cardiac services, we're talking about certificates of conformance for PCI and certificates of ongoing performance for both PCI and cardiac surgery. So we're behind schedule on getting these procedural regs updated. There's also been a variety of other changes in the law that need to be reflected in updated procedural regulations. But we're at a point now where we think we've done enough staff work and staff review that we're going to try to complete that and publish these on our website and send out word to the provider community that these are ready for informal review and comment. We hope to do that in June. These really don't lend themselves to a specific work group the way our state health plan regulations do. So what we're going to do is have a little bit longer informal review and comment period, make sure everyone has a chance to comment on these. And then based on those comments, we will decide later this summer if we need to convene work groups to address specific comment areas or particular types of changes that are being discussed that are really substantive changes to what we've put out as an informal draft. So we would hope to come back to you in the fall with a second draft based on the comments and any discussions that we have with commenters. And that would be a proposed regulation, procedural regulation. And that would start the formal promulgation process of an update to those regulations. So with that, we would ask you to approve the priorities and the timeline that we've outlined in the slides.
So I think on this one, since it's a complicated one, I thought I might give folks a chance to ask questions before we put a motion on the table.
Question.
Well, thanks for
Thanks for that nice review. It seems to me that the driver to update the state health plans is the frequency of use. With the rapid advances in information technology, does that have any impact on changes that should occur within that would drive the updates more frequently? I mean, 10 years is a long time in information technology. Should we have a regular update instead of waiting, depending on the frequency of use of it?
I would agree that 10 years is a long period of time in terms of the pace of change in information technology. But on the other hand, the issues that are dealt with in most state health plan chapters, which are really
Procedural or something?
what considerations go into determining whether you need usually either new facilities or expanded service capacity of the types that we regulate in facilities such as beds and operating rooms. I don't think those necessarily change that frequently. There's certainly plans we have here, plan chapters of regulation in the state health plan that are older than 5 years, closer to 10 years in age. But when you actually look at those standards and what guidance they provide for looking at the need for a project, whether it's a cost-effective approach to meeting needs, looking at the impact of a project on cost and charges or other components of the healthcare system, those are still pretty serviceable plans. They outline what you should be looking for in a project in a way that is still temporary in those cases. Over time, yeah, I would say that from my experience, once a plan starts getting to be like 10 years old, there's usually at least one or two standards that you can see in there that, yeah, they've become obsolete, perhaps because of changes in HSCRC's payment model, because we've certainly had pretty dramatic changes there in the last 10 years, or in some aspect of what has changed.
Just like the transplant health plan, I mean, technology and transplant advances quite rapidly, and I haven't read the standards for transplant, but I'm sure 10 years ago compared to now, the accepted standards should be different.
Yes, and if you look at the organ transplant standards now, which really have been updated in the last 5 years, and you look at the previous regulations that we had, you do see dramatic changes that are reflected.
That's the point I'm trying to make, technology impact on the update. Thanks.
I have a question, Paul. Is it, when you were doing a state health plan chapter, is the level of effort the same for all state health plan chapters? Or are there ones that are going to take more time than others?
I think that's true. The level of effort does vary.
I was just wondering, because I think this plan does a great job of assessing how outdated is it, and how frequently it's used, but are there also like, well, that one's as old and easy might be a reason to include it on the plan in addition to some other ones, if that were the case. And go ahead, man.
Yeah, I was going to ask Levon to go to the first slide in the deck, which talks about, if you go review that again, a lot of the effort is just how much public interest and engagement is. I know a number of commissioners were here who we included the nursing home chapter comprehensive care update, which took a couple of years. I remember that because then Chairman Pollack and I were summoned to the legislature a couple of times of what's taking so long. And I think the staff worked pretty hard. Paul's team worked really hard, but issues were raised by stakeholders that needed to be addressed, and pushing them through would have been a mistake. So we had to work through them. And even when we worked through them, it was with considerable input at the end that only then were we able to get those approved and signed as final. So that's a major factor. Certainly, scope and complexity of the plan chapter also contributes. I'll yield back to Paul for further clarification, but I think it's good to look at what we really value public input, even though sometimes it takes time.
And I think to illustrate the point, I don't think I'm giving away any secrets here. We're planning to start the process of updating our hospice chapter this year, and we anticipate that might be a more difficult and more complicated update process, simply because we know from our interaction with the hospice industry that some of the objectives that we have in this area are not supported by the industry. So we're expecting some pushback. We're hoping to have some constructive dialogue and perhaps be able to come up with some reasonable compromises in that approach. But compared to the other one that we've been working on, the General Hospital Services Standards, it's much more complicated because there isn't widespread disagreement on what makes sense in terms of updating that plan chapter.
Are there other commissioners with questions? Oh, I see a couple of hands. It's often hard for me to see whose hands are up. I do see Commissioner O'Grady and Commissioner Jensen. So I'll start with Commissioner O'Grady.
Yes, not to make this more complicated, but I do think there is a kind of a fundamental systemic problem that we have, in that on the number of the reviews that I've done, and when we go through and kind of look at the regs, there's still this vestige of what I think is a past point of view from the commission. This idea that is sort of it's an unfair advantage to the incumbents, in my just looking at it. Entry into the Maryland market it takes different forms in the different COMARs, but it's basically along the lines of you have to be better than the current players. So you either have to show a lot of excellence or you have to run them down in order to be able to show that you should. It's not that you're as good at them. It's not that you have the same quality scores. You have the same access scores. You have to be better than the incumbents. And that's a thumb on the scale. It bothers me every time I hit it. It's in the COMAR. So at points you kind of go, well, that's, without changing the actual reg, but now we're talking about, it's time to look at these regs and talk about them. And so it's one of those things that has gotten turned around, I think. We pride ourselves in our consultation. So we set up these work groups, but of course, people from outside the Maryland market who might, over the next 5 or 10 years, think they might like to apply for a CON, they're not on those work groups. The people from Pennsylvania aren't on, or New Jersey or Delaware or, Virginia or the DC. So we end up with this, like I say, it's a thumb on the scale that you have to show you're not only good enough for the Maryland market, you're better or we don't let you in. And maybe I'm not the only one that bothers, but it's a little too old boy, old girl for my comfort levels. And some don't have it, some have it very heavily, and it will make it harder. It's a heavier lift, there's no doubt about it, because the incumbents are well organized. But we're sort of the only ones who are in a position to push back on that and be the counterbalance when they would like to have a little bit of the same 5 providers, and you do these 2 counties and I'll do these 3, and we'll kind of divvy it up. Good for them. It's very good for them. Not good for the patients, not good for the taxpayers. And we're in a situation where, we've got some real answers to CMS about cost and the other commission's work. And I just think it's time when we talk about going through, and it's a theme throughout, Paul's, I might have moved transplant up into a higher category. But, other than that, that's Paul's kind of, he's the pro in this area. But, I've hit this across a number of these areas, and I don't like it. And I don't think we should perpetuate this. If we're opening up a COMAR, I think we got to set a level playing field. Whether you're somebody who I went to college with or not, doesn't matter. It's what you've got and what you can do for both the people of Maryland, both as patients and taxpayers. And it's just still too common in our COMARs.
Thank you, Commissioner Paul. Do you have any thoughts?
I understand what Commissioner O'Grady is talking about. I think if you look at the last 10 or 15 years, we have been successful in opening up opportunities for applicants to submit certificate of need applications for projects in a number of different categories that were not available before we updated those plans. I can think of at least 5 chapters of regulation where we had very restrictive entry requirements. And so effectively, through these regulations, you were creating a moratorium. We only have one chapter of regulation that I think still has that feature, and that is the comprehensive care facility, the nursing home standards, where we do have a strong priority expressed in those regulations for controlling nursing home bed supply. So that's the one area where we still are pretty inflexible. Unless we say there's a need for beds in jurisdiction, we don't accept and docket applications for review. But we've eliminated that in the rest of our plan. So there are opportunities. That's different from what Commissioner O'Grady is talking about. And so I think I accept that that is another feature that we need to look at. It's not enough necessarily to just open these up, but I think we do need to strongly consider whether we are being unnecessarily prohibitive in terms of what sort of performance requirements or quality performance issues that we are going to examine before we accept the ability of applicants to come in with projects. I think to some extent, some of the things we've done that I think are on point with Commissioner O'Grady's comments, we have tried to introduce the idea of performance using, what we think are widely accepted quality measures. So if you look at our nursing home chapter, if you look at home health, it's certainly something that's going to be part of the discussion on hospice. We are now kind of moving in the direction of saying, well, if we're going to have new entrants into the market, and for the existing providers in Maryland, if we are going to allow those existing providers to expand and have more capacity to serve more patients, we have been taking the approach generally in our plans when we have good performance measures to use, we've inserted those into the plan. And that's something we never had 10 years ago. We just did not have that sort of approach in the state health plan. So I think from my perspective, I think that's the area that we probably need to revisit and reconsider based on Commissioner O'Grady's comments. We are trying not to be too stringent. So for nursing homes and home health agencies, for example, we're using Nursing Home Compare, the measures that are adopted by CMS for that platform, and Home Health Compare. And essentially our updated chapters are saying, if you want to come in and be a new home health agency provider, you want to be a new nursing home provider in Maryland, we want to see that you're at least average or above average in terms of those compare scoring systems. And to some extent, you certainly are going to continue to have lots of nursing homes and home health agencies in Maryland that are not performing at an average level. They're subpar.
So part of our problem is that we can't revoke the certificate of need for the below average existing performers. That's sort of built into the process.
Yes.
But we still have a number of areas where if you tie with the local incumbents, that's not good enough to get entry. You have to show you're better. And I don't want anything I'm saying here to indicate this has gotten, Paul has done a great, as we've moved forward since whatever I started on the commission 6 years ago or something, it's all moving in the right direction. But if we're talking about opening them back up again, because candidly, I don't know whether the rest of the commissioners agree with me that this is a problem. I mean, it's clearly in the past the way Maryland did business for decades. I think it's a problem. I like kind of open markets, but if I'm I'm not interested in protecting vested interests. I'm interested in not hurting them and making it unfair to them, but I'm not interested in trying to give them kind of like I say, a thumb on the scale, that all they have to do is keep doing what they're doing. And as long as the new guys don't leave them in the dust, we're going to keep the new guys out. So it's like, I don't know, it's a theme, but it's seldom directly discussed in the commission. I think I've seen it across a number of areas where I've done reviews, and it's like I say, it's a vestige of an old way of thinking, I think, but I don't speak for the commission, you guys, it's sort of like.
If I could, I think I'd say.
Let's say it now as we head into a new review cycle, just so it's clear we have guidance to give to the staff. But if you guys disagree with me, vote me down. But I'd like to know the sense of the commission are the rest of you as concerned about this? Or you don't have to be as concerned as I am, but other things concerned about it and think it's not something we should put structures into our the Comars that again have this inside advantage, or whether we should just have a level playing field.
I've seen Commissioner Jensen and Commissioner Bandari have their hands up. Commissioner Gay, I'd note the point, if anybody wants to comment on that as well, I'll encourage folks to do so. I will say, just in response to your thing, I'll say for my piece, I definitely don't want rules that give an unfair competitive advantage to folks already in the state. I also don't want rules that allow a very low level out-of-state performers to come and supplement in-state under subpar performers. So I feel like there is a balance there that we should be keeping an eye on that issue as we approve new chapters, those are very fair questions to ask and to press on as we get down to details on any particular chapter. Let me turn it over to Commissioner Jensen's got his hand up for a very long time. And before I do that, Commissioner Jensen, I could only see about 4 commissioners on the monitor. So if you've had your hand up out there and you're wondering why I'm not calling on you, please feel free to speak up. Commissioner Jensen?
Oh, Chairman Sargent, this is Marcus Way. I'm not going to interrupt Commissioner Jensen. I just want to let you know my hand's up too.
Okay, thank you.
Thank you. I have 2 questions. First of all, I recall at our retreat that several conversations got wrapped up at the end by suggesting that they would be discussed in our annual assessment of the state health plan. And I'm wondering if anybody went back and looked at those minutes and found those issues and built them into this presentation. That's number one. And number 2, question number 2 is this. Is there any opportunity here to look at the timeline for prosecuting certificates of need? It seems to me, my understanding is that there's a statutory timeline which we rarely meet, number 1. And number 2, it just seems to me to not match up with the needs of the patients and the healthcare providers that it takes so long for certificates of need to get processed.
So I'll take those in reverse order. For many years, the deadline in the statute for completing these reviews it had no teeth. It basically said, get these done within, I think the two different deadlines were like 150 days and 180 days, depending on whether it was a contested review. And if you weren't completed in that time, the law said you can petition for the commission to make a decision. And so kind of, go to a judge and tell them that you need an order for the commission to act on this. So there really wasn't much in the way of teeth, and nobody ever did that, not surprisingly. For the last couple of years, we actually have a real deadline that we've introduced. Maybe we've been too conservative because we did not apply that deadline universally to every type of CON review. But we now have 120 days after docketing to take action on uncontested reviews with some exceptions, including establishing new hospitals. Cardiac surgery is another exception. There's a number of exceptions. But if it's an uncontested review and we don't take action within 120 days of docketing, it's an automatic approval. So we run out of time essentially, and the project is allowed to go forward. Probably also not surprising, we haven't let that happen in the last 2 years since we've had that in place. But that's kind of where we stand as far as timelines. We still take too long to review contested cases. That's kind of the big category where we have very lengthy review times. And there's still too much dead air time, I think, in those reviews. There's a reason why contested cases tend to take longer, but internally we've grappled with that. Part of the problem is we're trying to triage. So we're actually trying, we don't, it's not a first in, first out process here. And when we thought about kind of the general fairness of that approach, it kind of breaks down because you don't want to certainly take a lot of time for a facility that needs to expand capacity. You know, they've got a demand profile that clearly indicates we need more capacity for a service. You know, there's always an effort to try to get to those faster and get them done faster, and we do. That means that longer term projects where that sort of time issue really isn't. So if you want to introduce a new service, which is at a facility, for example, and there's a variety of existing providers already providing that service, that's not something that you really are going to lose a lot of money if you don't initiate that service. So those tend to get reprioritized. We will take longer times on those, but we're inserting other projects that may have come in later that do have a time issue related to them. On the other issue, what I recall from the retreat is that
Can I interrupt and just respond?
Sure.
Because I think that we should take a hard look at creating a more efficient process for the contested certificates of need and a deadline, because I believe that the commission inadvertently is used as a competitive leverage, right? If I don't want my competitors to get their certificate of need approved, I merely need to make it contested, and then that gets pushed out for sometimes years. And I don't think that that's appropriate for us to be used that way inadvertently. So I'd just like us to take a harder look at that. I mean, listen, I'm a lawyer, and I think part of the problem with the process is we have too many lawyers involved. Because a lawyer, by definition, if I don't want you to get a competitive certificate of need approved, all I have to do is hire a lawyer, and they can ball it up forever. And it just doesn't seem to me we should be used that way. So that's my editorial comment, but I think it's something that we ought to seriously consider.
Let me ask a question, Paul, on that vein. Is that part of the procedural regulations we're working on?
Procedural regulations are definitely an area that we would address that problem. And so I would.
Okay, because I think Commissioner Jensen has a good point. We want to speed it up as fast as possible, and that seems to me the place where we would be looking into doing that.
And that's the procedural slide that was presented, right?
The last slide, yes.
Yeah. Okay, good. Thanks. Sorry to interrupt you, Paul. You had the second question, and then.
So the first issue you raised was the state health plan, and I was at that retreat.
And we were at our retreat, and several issues got punted too. Let's talk about that when we look at the state health plan. And I just wondered if somebody took a look back at what those issues were, if they got built into the slides that you.
My look back indicated that the discussion was there really wasn't so much discussion of changes in the state health plan as it is currently formatted, and as it basically has been formatted for a long time, which is that it's not really a plan. It's not what most people, when they hear the word plan, would recognize in our state health plan regulations. State health plan has become project review standards. So that really happened in the late 1980s, actually, early 1990s is when that changed. And there was discussion at the retreat of, do we want to think about a state health plan and an approach to developing what we call the state health plan that kind of returns to the older model of the state health plan that started out. In other words, not just for project review standards, but do we want to have a more conventional plan that really talks about what sort of healthcare delivery system do we want, or at least in certain categories of service, what sort of delivery system do we want? What do we see as the problems or gaps in having, a better model of the healthcare delivery system? And therefore kind of proactively identifying what are the changes that we'd like to see in the state health plan. And I think the tenor of the discussion was that doesn't necessarily mean something that we regulate under CON or that necessarily directly relates to project review. But would there be value in having a state health plan that kind of proactively provides direction to the provider community on changes, whether they be within our regulatory oversight or not, that we think are necessary in the way resources are allocated or the way that service delivery is organized. I'm not trying to address that here. I think that's a discussion that we should continue to have. And I'm certainly open to rethinking what is the state health plan. But at this point in time, perhaps unfortunately, I'm still dealing with the type of model state health plan that we have had for many decades. And I'm just trying to lay out my thoughts on what are the priorities in terms of updating, again, what are essentially project review standards.
Okay, thank you very much.
Dr. Bandari, and then Commissioner Wang, you're on deck. Commissioner
Thank
Bandari?
you for the wonderful presentation. I have a question about general hospice services. You mentioned many jurisdictions has single general hospice provider. What is the reason some has single and other has more than one hospice provider? Because I think for the general public and for the patients, more than one is always a better option. Can you just clarify what was the reason for single hospice provider?
Well, I think the reason this has occurred is because for many years, actually until, well, I guess I would say it's still really kind of the current approach in our hospice chapter of regulation, which is wrong. It is regulation at a jurisdictional level. So not surprisingly, when you look at these jurisdictions where there is only one authorized hospice provider, they tend to be some of the smaller jurisdictions, not in every case, but certainly the smaller population, the rural jurisdictions, that's where you see that condition, where there's only one provider. And clearly it doesn't make sense for us to try to open up a jurisdiction that has one authorized hospice provider and say, hey, we're looking for people to come in here and develop a hospice to serve this jurisdiction. They're too small. You're not going to get any interest. So I think, a key part of what we're going to be proposing in discussing an update to this regulation is we need to finally get rid of this jurisdictional approach. We need to look at regions. We need to create regions that create large enough markets that you might generate some interest, either by someone coming into Maryland to establish a new hospice, or for existing hospices, they would have a more attractive option if they could expand into a 3-county area or a 4-county area instead of just one. So when we look at the areas that we want to have some impact on, it's Southern Maryland, it's the Eastern Shore, and it's Western Maryland. And certainly when you look at Southern Maryland, I think we can viably create a regional approach where we would have possibly have some new entrants, possibly have some expanding hospices, but we would be giving them a viable market to expand into or to establish a new service. The Eastern Shore, we really have throughout the Eastern Shore, with the exception of Cecil County, single hospice jurisdictions. And we have 2 hospices who kind of carve up that, that area. But as a region, you know, it's a few 100,000 people. So we think that there again, that would be an area that if we say this whole region is available as an opportunity for entering the market or for expanding, we might have some success in at least getting some of those jurisdictions with more than one choice of a hospice provider. Western Maryland is tougher because it's bigger geographically. And I think it's a more difficult economic proposition to try to serve those large Western jurisdictions. And again, they're not the biggest population areas. So we might have to be creative in thinking about some different approaches to attracting competition there. The pushback that I referred to earlier is kind of the flip side of that. When you have a very small hospice serving just one jurisdiction and it's not a big jurisdiction, then obviously they're very nervous, quite rightly, about competition coming into their small jurisdiction. But I think if you can frame this as a regional approach, in which they would also have an opportunity to expand within their region if they're willing to take that step, I think we might have some success, maybe not in eliminating all of these single hospice jurisdictions, but at least some of them. Thank you.
Thank you so much. Thank you for the clarification.
Commissioner Wang.
Thank you, Mr. Chairman. It's good to be here virtually. But, I want to say I agree with Commissioner Jensen that we don't want to allow folks to misuse the commission to delay the process for their potential competitors. And I think we can all agree we want the process to be thorough, comprehensive, and as efficient as possible. And in my experience, the staff of the commission is already doing a really great job with that. And I wanted to follow up on Commissioner O'Grady's great comments with my own perspective. Because like you, I'm a firm free market evangelist. I'm a business owner, I'm an entrepreneur. And actually, I came onto this commission believing that the CON process was a barrier to new entrants and a hindrance to access to healthcare. But today I'm here to say I no longer believe that. I think private sector principles, free market principles are fine when you're dealing with end-use consumers who have a choice. They're buying a t-shirt or a car, they're making a choice they don't need to make. It's up to them. Buy the Nikes, don't buy the Nikes. Water will find its own level, right? But people don't choose to break their leg or get cancer. And the end user of this healthcare system here isn't really a consumer in the typical sense. So we can't construct the infrastructure around them as though having, breast cancer or drug addiction is a lifestyle choice akin to, what brand of jeans you prefer. So I think we have to continue to regulate. We have to gatekeep. We have to hold new entrants to the highest of standards, higher than before if necessary, because I believe that is ultimately in the best interests of the end users, the people of Maryland.
And I would concur with that. I would just say I don't want to hold the new entrants to a higher standard than the current players. I would just want a level playing field.
And Commissioners, thank you. I think those are both excellent, both areas, meaning looking at competitiveness and the standards for individual CON and looking at the question of how do we make the CONs faster are really important issues. And I just wanted to highlight for the commissioners, here's what we can do to help. Procedural regulations are not even exciting for lawyers to read. But as you can see, when they come out, they are important. And that's the roadmap that determines how fast the CON go. So think about when we get a set of draft procedural regulations to review, how do we approach that to make sure that we're doing our job to clearing out procedural barriers? And I'd encourage the staff to think about when that comes, that may be more regulations than average non-lawyer commissioners can just read through over the weekend. Are there ways that you can educate us on those drafts you know, and maybe it's not a special session or a special just educational meeting that doesn't make decisions or something to make sure that we can understand that and where the choices are made. And then as individual sections of the health plan come up, Commissioner Grady, I absolutely think we should be considering when we change the regulations for a particular type of CON, do we have the concerns that you expressed in mind? Are there any other questions or comments about the status, the priority order and timeline? With that, we have a legislative duty to adopt and to conduct a review and adopt a priority order and timeline. Is there anyone who would like to make a motion to adopt the annual assessment of the state health plan priorities and timeline for review and revision of state health plan regulations?
So moved.
Commissioner O'Connor moved. Do I have a second?
Second.
Commissioner Gordon?
Dari,
I'm sorry, Commissioner Jordan won. I appreciate it though. With that, I'll take, unless anybody has any additional questions or comments.
Randy, I ask this every year when we go through this, and you would make us aware of a situation where somebody wants to apply for one of our regulations. None of them are on hold, or that they're prevented from applying because it's just not possible, such as somebody wants to add an OB unit, even though you don't think they might, or something like this. Or the beds, or whatever it is. Forget open heart surgery, but just basic things. This is not going to restrict in the next year anybody from applying.
No.
Thank you.
One other question too. Paul, you talked about competition among the hospice agencies. Do we have any numbers in regard to the optimum number of hospice workers per aged population?
I don't think we have anything.
If we have the number of surgeons you need for population, anything about hospice workers per aged population?
No, don't have staff to population ratios.
But you really can't use population as a gauge as need for hospice. It would have to be aged population.
One of the problems you have with
Eastern Shore is very old.
One of the problems you have with hospice and home health in terms of trying to regulate those under CON is it's different from some of the other things we regulate that I don't think it's actually possible to say the state of Maryland or some region in Maryland needs this many hospices or this many home health agencies. Obviously, you can have a big home health agency that serves lots of jurisdictions and can do a good job doing that.
I meant hospice workers per se, not number of agencies. Thank you.
Thank you. With that, I'll call the question. All in favor of the motion to approve the annual assessment and setting priorities?
Approved.
Are there any opposed? Excellent. Motion passes. Thank you, Paul.
Thank you.
Just, I think it was a very good discussion. I think the points that were raised by the commissioners are all ones that you'll really take to heart on the part of the staff. The point that the chair made about some of the issues related to what constitutes an interested party in the process through which a contested case can be is prosecuted, if you will, can be addressed through changes to the procedural regs. The broader policy and aspirational issues of a state plan really, I think, are topics for our strategic planning initiative. The preambles, if you will, to some of the state health plan chapters really lay out some very broad objectives, but the regulations themselves, as Paul described, are rule-based, and I think we can think about how aspirational elements could be included in some of those plan chapters where they are highly relevant. So we'll look forward to that discussion. But I thought it was very helpful for staff today.
Thank you, and thank you for the commissioners who participated. Turning to agenda item number 6, Maryland MCDB data request application by Johns Hopkins Center for Public Health IT. Under our statute and the regulations governing access to MCDB data for research use, the commission must approve an application for MCDB data prior to the release of MCDB data to an applicant. The Center for Population Health IT, Johns Hopkins Bloomberg School of Public Health, has applied for the MCDB data. The applicant will use MCDB forms, HSCRC hospital records, and information from the Office of the Chief Medical Examiner to enhance Maryland's statewide suicide data warehouse for predicting suicide risk and preventing death by suicide. It says here that Mahi Kanjit Solomon, Chief of.
I'm mentioning.
Yes.
Mahi's not well today.
If they can, you know.
Yes, Mahi's not well today. So
Chaplain will give the
I'm stepping
presentation.
in for Mahi. Hope she gets well soon.
Very good.
Thank you, Chair Parkman, Chair Sargent. Sorry about that. Commissioners, good afternoon. Executive Director, staff, and members of the public. Happy to be here today. Next slide, please. In the process of how we actually this data, we govern it by the COMA 102505, and there's an application that the applicant fills out. An application is posted for public comment, and the data release advisory committee use public comment to review that data, and then also a DUA is actually formed, and then the track recommends the application to come to the commission. That is why we are here today. Next slide, please. So the applicant in this case is the Center for Population Health IT, Johns Hopkins Bloomberg School of Public Health. On the left-hand side of the slide, Johns Hopkins, I will refer to as Johns Hopkins, have successfully had 5 projects in which they have used the MCDB in the past. But today, the applicant is requesting MCDB data for the research project for advancing Maryland's statewide suicide data warehouse to improve individual and population level mortality prediction and prevention. There has been increased interest in developing models, predictive models, to identify individuals at risk for suicide. The National Academies of Science, Engineering, and Medicine are currently hosting a series of webinars using data science approaches to identify individuals, population, communities at high risk for suicide. Next slide, please. In terms of the project, the purpose of the project is to refresh the Maryland Suicide Data Warehouse and acquiring new data from different sources and application of descriptive findings, develop and assess hypothesis-driven techniques to predict suicide death. Also to explore the hypothesis-generating use cases of the Maryland Suicide Data Warehouse and to evaluate the generalizability of data sources and methods. In terms of the data sources that is going to be used for this project, the MCDB data will be linked to the Office of the Medical Examiner by a crisp encrypted EID. Other data sources will be from the HSCRC, Johns Hopkins Health Systems, Anne Arundel Medical Center, Peninsula Regional Medical Center, Veterans Health Administration of Maryland, and Chris Insight. So the proposed project will compare individuals who have died by suicide to those who have died by other means as specified in the Office of the Medical Examiner data. The project is proposed to build a complete control population as recommended by the National Institute of Mental Health. The project will also develop a more generalizable predictive or prediction model Also will develop predictive analytics using statistical approaches to identify suicide deaths. I also will construct a retroactive case control study exploring suicide as recorded by the medical examiner and other cases of death. And the analysis will be studied by race, gender, insurance type, and other attributes as needed. Funding source for this project is the National Institutes of Mental Health. Next slide, please. In terms of the project, the data requested would be the MCDB eligibility files and all the claims files, professional services, institutional services, and pharmacy services claims file for the privately insured data and also the Medicare managed care data for the years 2016 to 2020. The projected time period for this project is a 2-year period, which will span 2022 to 2024. From a results outcome basis, the results on the project will be disseminated through published peer review manuscripts and conferences. Additional aggregate results may be shared with the funding agency NIMH as requested by the National Institute for Health Guidelines. The data fees for this project will be $96,000, and it will be based on a new fee schedule which will become effective June 16, 2022 after a 30-day notice. Next slide, please. Today, we have the Hopkins team, Hardy Karazi, which is Associate Professor and Co-Director, Thomas Richards, who's the Technical Director, and we have Elise Laser, who is the Research Associate and Center Coordinator. Next slide, please. So upon review, staff have determined that the application meets the regulatory requirement of research use because the aim is to leverage the unique data types linked by the Maryland Suicide Data Warehouse to improve suicide death predictions among a more generalizable patient population in Maryland. Staff also reviewed and says that the application meets the regulatory requirement of being in the public interest, as the MCDB and other data sources and other data could be linked to data from suicide prevention efforts to help identify which interventions are most effective in preventing suicidal behaviors and who benefits from specific interventions under what conditions. Predictive models of suicide death will be available to the public and can be adopted by various health systems and insurers. Therefore, staff recommends the Commission to vote to approve the MCDB data request application submitted by applicant John Hopkins, the Center for Public Health IT, John Hopkins Bloomingburg School of Public Health, and provide access to the required data. Staff also recommends that the Commission approve the applicant's request for the requested data until the end of 2024, beginning on the dates the data use agreement is executed and the new tiered fee schedule effective tentatively June 16th. Next slide, please. Next slide, please. That is my end of my presentation. Any questions?
Very good. That's sweet. Yeah, we can do questions first. Commissioner Boyle, I see your hand up.
Yes, thank you. I mean, this looks like a great project. It's not, I don't question that. This is the first project I've seen that they're actually paying for it and they're not asking for an exemption to that. I'm just a little curious about, like to better understand why, what is the payment structure? How was that developed? And I do know that we have exempted many, but is the amount of money, is there fear that that stands in the way of some people applying?
Well, that's a very, very good question. Well, we as a commission do not want payments to be a hindrance to use ABCD, expand ABCD. And in terms of, for this case and going forward, we have a new fee structure based on a tiered basis. So what that means is that for an applicant who, to have a discount, applicant will apply for the data for at least 3 years or more to really get the discount. So in this case for John Hopkins, they are applying for the data for 5 years. So for the first 2 years, there will be no discount. Starting in year 3, there will be a 25% discount, year 4, 25% discount. And then in year 5, there will be a 50% discount. So, so for this case, for the private data, that will be $48,000. For the Medicaid data, that will be another $48,000 for a summation of $96,000.
I noticed Dr. Karazi is on a video, and I wanted to thank you for coming. So if commissioners have a question, he is also here with us. Are there any other commissioners who have a question or discussion?
Yes, I do, Randy, if you have a second.
Right ahead.
Okay, so I think this looks like a great project. And I would say to my fellow commissioner, I think NIH is picking up the bill for this one, and so I wouldn't worry too much. They have pretty deep pockets. So I think it's the end, because we do at times waive and make it, you know, below the regular rate. That hopefully should avoid any kind of chilling effect on less well-funded researchers coming forward. The main thing I wanted to say here is I think this is, I like this project. This looks very good. And not only, the only question I have is about the dissemination plan. And this is simply a suggestion. I'm still very fully supportive. But it is taking a traditional academic style dissemination plan. You know, we're going to publish. And God knows, you know, we all understand you have to publish. You need, that's how you move up in your field and things like that. At the same time, there are so many, let's call it applied uses for this modeling if you are successful. I would ask you to consider not only sort of this dissemination plan that is the traditional academic style, which I'm sure NIH will be quite comfortable with. But in my experience, there's been too many times when there's good models like this in the echo chamber of an academic audience, and the people who are actually trying to help reduce suicides are just unaware of it. So I would ask you to consider, do you want to try and when you've got something, you know, hopefully it's good and you're comfortable with it and, you know, you've got it published, you're not trying to, but I would say go back to the state of Maryland and if you'd like to come back to us, I'd love to hear about what you actually find and how robust this model is and how well it predicts and how well it does for different demographics or different vulnerable groups. But I think if you are successful, there is great potential for this to do more good than publication. And I would ask you to consider how you get this to more the practitioners who are actually on the ground, whether it's county level, state level, federal level. This is, you know, the Surgeon General has a big program at HHS. There's these things. This should not sit and go, you know, be published in a peer-reviewed, but then kind of a report that sits on the bookcase at NIH. Because candidly, my experience at HHS for a number of years was that's far too often what happens to this. And so the Medicare people actually never see it. The SAMHSA people never see it. It never gets out there because those guys are in a different world and they're not going to sit around and read your journal. So it's just a suggestion. But if you really want this to make a difference, I think you've got to think broader in your dissemination program.
Just a comment along a segue with Commissioner Grady said, I think it'd be a great idea if they can predict the inclination towards suicide, I wonder if they can use data and predict violent behavior. I mean, just a thought.
So I had a question, maybe more of a comment, Ken. Just, it's similar to what Commissioner O'Grady just said. I think this is a no-brainer, so it's not really about this, but I would love to see just a general program that we, maybe not program, but general practice we have where we've contributed to research by putting our data in. And a paper comes out. Are we collecting those, making sure that folks are aware that we've contributed to that research? Do we have a process in place for tracking that, for getting the results, and for helping to share them ourselves? And what can we do on that end, in addition to the excellent suggestions for the researchers? But it's good for us, it's good for the research, and things like that. So I don't know if it's so much an answer, unless you already have one in place, but or something to think about.
Well, not only in this research as well. I know Dr. Karazi will present the commission on its findings, but we with our contractor, we are looking to develop a series of visual studies where we will actually use the ABCD and look at some of these challenging topics, to actually do these research in-house as well and present it to the commission, and the public could actually benefit from it as well.
Thank you. And Dr. Karazi, did you have anything that you wanted to? I know Commissioner O'Grady had some.
I just want to thank the commission, and I totally agree. That is our purpose. Of course, we will publish to have a permanent record of the models, but we are in touch with different entities to share our models. There are also 2 other centers that develop on a national scale. They're developing these suicide models. It's Kaiser Permanente and the VA have worked heavily in this area. So we are comparing models. We will be comparing models and seeing, how we can generalize it. The models would be available in the public domain, and whether there are different vendors or different entities out there that they want to adopt the model and put it in operations. We are more than happy to share those. We will share the results, of course, with the commission, and also we hope that hopefully a version of this model could be implemented by CRISP. Because CRISP receives real-time data, they can notify, the primary care physician in charge or the hospital that an encounter is happening about, a high likelihood of maybe suicidal ideation or attempt. So, so that is our vision, but we'll see how much we can achieve. So we certainly thrive to do that, but operations is not part of the research, but we hope to be able to get there. Appreciate any comments or any hints that you would have to help us on doing that. We will certainly follow the leads.
Thank you, Doctor. I did have one question. Actually, I had 100, but it's not, because it's a fascinating piece of research. The one I had was just given the disparity between male and female suicide rates, essentially because men are better at accomplishing suicide, so there are many more female suicide attempts. Are you including attempted suicide in your analysis as well, as in addition to suicide deaths?
Well, this is actually why NIMH was interested in our research, because we are not only predicting attempt, we are predicting death as well. That's why we have the medical examiner data, because there are not that many models that predict death. There are many models that predict attempt. So yes, we are predicting it in both sexes. We are also stratifying and trying to see whether there are different prediction models for different subpopulations, especially among our vulnerable and minority population, because that data is often not available. But in this case, because we are bringing in data from multiple sources, we hope to also do better predictions in our gender minorities or racial minorities, and also in certain segments of the population that we often can't do good predictions. So, so yes, the short answer is yes.
Thank you. Can I get a motion to approve?
A second.
Okay, I missed it. Was it Commissioner Jensen that moved?
No.
I'm sorry, who moved? Commissioner O'Grady. And I couldn't see who second.
Commissioner Wood.
Commissioner Wood, thank you. All in favor?
Aye.
Aye.
Are there any opposed? Great, the motion passes. Good luck, Dr. Karazi.
Thank you so much. I appreciate your support.
Turning to agenda item number 7. We have an update on practice transformation grant activities. I want to thank you both. I know it's been a long discussion. You've waited patiently. The MHCC released an announcement for grant applications in May of 2021 to identify a care transformation organization, or CTO, to engage small primary care and specialty practices in a practice transformation program. The MedChi CTO was competitively selected to complete the transformation activities in June of 2021. A vital role of MedChi CTO is to coach practices on specific transformation topics and approaches like quality improvement, as well as tools to help sequence and manage change essential to success in a value-based model. Melanie Cavalieri, did I say that correctly?
Yep.
Chief of Innovative Care Delivery, and Gene Ransom, MedChi CEO, will provide an update on the practice transformation grant activities. Welcome, Mr. Ransom. Melanie and Gene, you have the floor.
Thank you, Chairman Sargent and Commissioners. Next slide, please. I'd first like to provide the background on the grant. As Commissioner Sargent mentioned, this grant was released in May of 2021. The grant objectives include prepare practices to deliver efficient, high-quality care while improving health outcomes, lay the foundation for practices to provide team-based, patient-centered care, and for efficient use of health information technology, and to support the total cost of care model goals by readying practices to participate in value-based care models. Next slide, please. Chairman Sargent also mentioned in June of 2021, MedChi CTO was competitively awarded a grant in the amount of $550,000 to complete practice transformation activities. I will go into more detail on the practice transformation activities on the following slides. Next slide, please. The CMS Transforming Clinical Practice Initiative, or TCPI model, serves as the framework for milestones 1 and 3, and the Office of the National Coordinator for Health Information Technology Workflow Redesign Templates provides the framework for milestone 2. Milestone 1 is a readiness assessment. Milestone 2 is workflow redesign. Milestone 3 is up to 7 training packages using the support change package modules. Next slide. I will go into more detail on milestones 1 and 2 later in the presentation. Milestone 3 practice training includes virtual or in-person sessions with MedChi CTO. This training may take up to 12 months to complete. The training provides practices with techniques to help improve patient outcomes. The 7 TCPI modules are listed on this slide. Next slide. I'll now provide some information about the practice applicants and participants. Next slide. First, I'll tell you about the applicants. 64 practices applied to participate in the program. 48% were specialists and 52% primary care. 18 different specialties applied, including cardiology, ophthalmology, and gastroenterology. These 3 specialties are eligible to participate in the Episode Quality Improvement Program, or EQIP, which you'll hear more about later. Now I'll review the participants selected for the program. 48 practices were accepted into the program based on combined assessment scores across key drivers that included patient and family-centered care design, continuous data-driven quality improvement, and sustainable business operations. The percentage of specialists in primary care practices remained the same. Next slide. This slide shows the sum by county for the participants. Montgomery and Baltimore County had the highest number of participants with 9 each. Next slide, please. I'll now discuss the transformation activities. Next slide. Practices completed a baseline readiness assessment using the practice assessment tool. The results of the assessment identify areas requiring technical assistance, which become the focus for work performed by MedChi CTO and supported by specific modules in the change package. Next slide, please. Practice work plans contain suggested transformation activities, including trainings and workflow redesign. The practice transformation progress is reassessed by MedChi CTO quarterly. The scores will be used to determine the practice's progress through milestones, evaluate additional technical assistance needed to support the transformation efforts, and inform any practice work plan revisions. Next slide. Workflow redesign involves remapping workflows and shifting responsibilities among staff to maximize practice efficiency. MedChi CTO will work collaboratively with practice leadership to implement these workflows reflective of the unique processes at each practice. Next slide. Value-based care models that are currently available in Maryland include accountable care organizations, clinically integrated networks, the MD-PCP and EQUIP, as well as patient-centered medical home and capitated programs. Next slide. New VBC models, including EQUIP and Care First Specialty Medical Home, have spurred additional practice interest, especially among small independent specialists. An additional grant amount of up to $275,000 was awarded to MedChi CTO to complete transformation activities for up to 25 practices. The second round begins July 1st of 2022 and ends June 30th of 2024. Next slide, please. The next step for round one activities include finalizing the practice work plans by the end of May, reviewing and implementing the practice workflow redesign with participants in May and June, and beginning the practice training sessions in July. The next steps for round two include a 90-day practice recruitment period, which begins July 1st. Next slide, please. Next slide, please. I'll now turn the presentation over to Jean Ransom, who will provide information on grant alignment and the focus of the transformation activities.
So first of all, I want to, and I've privately congratulated Chair Sargent for his ascension, but we're looking forward to working with you, and congratulations on your ascension.
Exactly.
Well, you're higher up than you were the day before. We'll have to work on that. You should get a hat and a scepter. Anyway, so you can go ahead and go to the next slide. I think one of the first places to start is why are we doing this? And I think that's, when we're doing something, why are we spending this money? What's the benefit of it? Well, as you're all aware, we're in a total cost of care model. That total cost of care model, traditionally, prior to the last 10 years, really was focused on hospitals. And one of the things that CMMI and CMS wants us to do is to align physicians and other community practitioners with the model. This has been a challenge as we move forward that we face because the economic alignment is not there. Physicians are still principally paid on fee for service. And when you have hospitals who are paid on global budgets and physicians who are paid on fee for service, that can at times create tensions and problems. So what we're trying to do, and we've said for quite some time, and those of us who've been around a while remember first there was the triple aim, and we talked about how we were going to go to value-based care, but this time we're really going to do it, and we've got a series of value-based care programs that we're going to try to make work by making them work the way physicians like to work and the way they used to work. So the goal here is to look at physicians who have traditionally done fee-for-service for a long time and help them transform their practice into value-based care. If we are able to do that, then obviously that will help us be successful as we come to the end of the 5-year period for our total cost of care. And we have to go to CMMI and say, hey, we'd like to keep the waiver or the total cost of care agreement in Maryland. We're going to be able to say, look, we have made progress, and that's why it's important. So that's why we're doing this. That's the reason. So we really appreciate the fact that our CTO was selected through the competitive process to do the work, and we're very excited about where we are. Our goal is to try to get these practices ready, able, and to be successful in programs like the Maryland Primary Care Program, like EQUIP, which I'll talk a little bit more about in a second, and also the private payer programs that are out there. Care First is currently expanding their bundle payment program, and other private payers also have ACO-like models and other value-based type products. And it's really important that as we move forward, we do this in an aligned fashion where we protect the rights of patients and physicians focusing on the public health of Maryland. Next slide. So with regards to the first activity, I think Melanie did a good job going through what we're doing kind of with round one and round two. To put some real numbers on it, we have completed all of the practice assessments for all the applicants for round one. So that's terrific. We are beginning to do the redesign work. In fact, we met with a small practice yesterday in Prince George's County, had a very productive redesign meeting, and we'll be doing that to determine which trainings are appropriate for each of the practices. We are not just confining our help and activities to the trainings that are outlined under the CMMI model. Some of these practices might have unique issues with regards to how private payer contracts or other issues might be necessary. And we're considering that included in the grant, even though it wasn't in the four corners of it, because obviously we think it's really important that the practice is able to be successful in this space and they understand what they're getting into. So with regards to the second grant, what we're really going to do is try to target the specialties that Melanie outlined earlier that will be encompassed and equipped. And what I'm going to do now is I'll come back to round two at the end of this, but I'm going to go ahead and talk a little bit about equip. Obviously, all of you are very familiar with the Maryland Primary Care Program because Ben does such a great job staffing the advisory committee, and I'm sure you hear updates about that. So I think you understand getting practices ready for that. Equip, though, is something that you probably have not heard a lot about. Go ahead and go to the next slide. So Equip, the episode quality improvement program, you can go ahead and go to the next slide. Is there another slide?
Yeah, there's a slide.
There we go. So the episode quality improvement program was created by the HSCRC with MedChi, and I happen to, and have for the last 5 or so years, chaired the committee that kind of does the advisory work on Equip. It was launched finally and approved by CMMI and CMS last year for a handful of specialties, orthopedics, GI, and cardiology, but only for limited codes under those specialties. To summarize it in a very basic way so it's easy to understand, it's really a bundled payment program. It's a value-based program where physicians are incentivized to provide for certain bundles a higher quality. They have certain quality measures they need to meet, and they need to, under that program, try to save money during the course of the bundle, as well as hit these quality measures. If they're able to do that, they can get shared savings. One of the great things about the EQUIP program, at least so far, we've had some pushback from CMMI, is there's no risk involved. So it's very easy for physicians to get into it. One of the other things we did with regards to EQUIP, and this strategic decision was made very early on, actually in a collaborative fashion with CareFirst, MedChi, and others, we decided to use the Prometheus grouper, which is a set of codes that was developed for EQUIP. These are the same codes that CareFirst is using for their value-based programs. One of the complaints we often hear, and Dr. O'Connor can probably back me up on this, every insurance company and every program has its own set of rules and quality measures and things you have to do. And there's nothing more frustrating for a physician than being in a program and having to do X, Y, or Z with regards to one program. And then the next patient with the same case, but has a different payer, has to do something different. So that aligned the two programs, the private and the public, and we think that's a big positive. Unfortunately, we weren't smart enough to do that when we developed the CareFirst primary care program and the MDPCP program, but I think we've learned our lesson on the specialist side as we move forward. You can go ahead and go to the next slide. Next slide. There we go. So I actually kind of already covered most of the next slide when I was going along with regards to it. And next slide again. All right. So before I go into the next steps, which is something that Ben actually mentioned in his initial opening, I will also say that going back to the second round of the grant, we are currently working, and MedChi, the HSCRC, and CRISP are working together on an application of CMMI to expand EQUIP for next year. We do expect, and you'll hear this if you want to tune in tomorrow to the EQUIP meeting, which is at 9 o'clock tomorrow morning. So you're going to hear it before them here today. But we are hoping to add codes around emergency room physicians, urologists, ophthalmology, and dermatology in the application of CMMI. We are also going to add additional bundles under the 3 specialties that were included. So that's going to be, hopefully we'll have an expanded EQUIP program for next year, and we'll get more physicians involved. So as a result of that, it makes a lot of sense, and it's very logical what you've done by expanding the grant. We're going to specifically target specialists in these new areas for the second round of the grant. So as we do that transformation work, we can begin to prepare them to sign up for EQIP and participate in those programs. I would also note the specialties that we are picking, working with the HSCRC and with the state for the application for EQIP, match very closely to where some of the payers are going with regards to their bundled payment contracting. And that brings me to the legislation that just passed. After a lot of tension and work over several years, because MedChi was very concerned about early versions of the legislation that didn't have caps on risk, we did come to a collaborative agreement with the Maryland Hospital Association and Care First. And I think Director Stefan did a very good job going through that earlier, so I will not reiterate that. So in closing, I've got to say, I've worked for MedChi now for 25 years, both as a lawyer and an executive director. I can't say enough about how great a relationship we've had with the commission since Mr. Steff has taken over as executive director. And I also want to commend specifically Melanie and Anene, who have been working very closely with our staff. They are excellent. I will tell you, they are stewards and guardians of your money. They're making sure that the work is getting done, it's getting done right, but they're also pleasant, nice people who are fun to work with. This is really a good project. I feel like we're making a difference and we're helping docs provide better services to their patients. So it's something we're very proud of and we really appreciate working with you on it.
Great, thank you, Mr. Ransom. Are there any commissioners with questions? Dr. O'Connor?
Jane, how you doing?
Good to see you.
Just one quick question about these value-based practices. The specialists and the primary care, are they integrated at any network level to make better decisions about what tests to order, save money in that regard? So there's no redundancy? Or are they still autonomous, specialists, primary care?
That's a really good point. So from a practical point of view, in most cases, it really is autonomous. And the way the programs are set up, they're somewhat autonomous. And one of the things I don't like about how we're moving forward with this as the person who runs MedChi from a staff point of view is that at times it creates tension where our specialists in primary care fight. And that's not good. We don't want that, right? The EQIP program really is a very proceduralist, specialist-based program where they're focused on a procedure, and the Maryland Primary Care Program is really a program where primary care is focused on cost. There are some practices where they're integrated. You know, you have some larger private practices like Privia or Clinical Associates that have a mix of specialists and primary care where they try to work together. And then you have hospitals who have integrated CINs, like the one that Mr. Doran used to run, where it has an integrated CIN and they try to have the specialists and the primary docs work together. I think that's one of the things maybe for round 5 or 6 of this grant, whenever we get there, we need to think about how we all work together. And then another glaring issue that we need to deal with, which I would love to figure out, and I think a lot of people would love to figure out, is drug costs. You know, most of these programs do not properly incentivize practitioners to focus on that. And not only, you know, have we not figured out how to break the silos down, that's a really big cost that keeps going up that is really hard to incentivize folks on for various reasons. And really hard to control. And I think that's another glaring issue that we need to work on as we kind of move forward and do value-based care right.
I would just add one thing about the program itself. So although they're not integrated, well, there are a lot of trainings about using the medical neighborhood and closing the referral loop and doing things like that, and things to avoid a test that was delivered at a specialist just because you didn't know it was delivered. So 2 people ordering the same thing. So those are components of the trainings, but they're probably not going to be integrated like the specialist and the PCP won't be sitting there side by side in the training. Those trainings will be delivered independently. And we're also doing, as part of our learning network, we're doing several training or peer learning events that are about that very thing, and doing care coordination with specialists in primary care.
And one of the other things too is both EQIP and MD-PCP specifically require a higher level of CRISP adaptivity for participation. So that does allow for the practitioners to have more information about things that have been ordered. So it does allow them to maybe avoid double ordering and things like that. I also think, and MedChi supported this legislation, some of my colleagues from other states were surprised that we were willing to. I think the bill that Ben also mentioned about all medication and CRISP and the PDMP is going to be helpful, because I think we will have people understand that, this has been ordered, we don't need to do it twice, or wait a second, we've got 3 or 4 things that don't match up here. And that will help with some bad outcomes and maybe with some double ordering of medicine. So I think that's another positive step too.
Commissioner Bandari, I see you have your hand up.
Thank you, Mr. Henson. Thank you for the wonderful presentation. I have 2 questions. One is how you pick the specialties. Second, certain specialty. I'm an oncologist, in this total cost of care model, is that chemotherapy, diagnostic testing, molecular testing, which is now we order quite often, is it that part of that? And, another specialty I can give you example is orthopedics, the hip replacement, joint replacement is very expensive. And I look at these specialties, I don't see orthopedics in that. I know there is oncology, but no practice has accepted that. Can you please clarify these things?
So let me answer your first question first, then I'll go to your second. So the way we pick, and this is really in my role as chair of EQIP, and frankly, I'm not really the decision maker. Obviously, the HSCRC is the decision maker, ultimately the commission. But Medkai and Chris have a lot of influence because we're the ones who staff and control the committee. So what we've been doing to decide who is in the program is we are really doing it based on which specialty wants to work with us. Now, interestingly, oncology was one of the ones we tried to work with very early on. We've had multiple meetings with them, and Dr. Solano is actually on the EQIP committee. He's the president of BDESCO, the Maryland Oncology Society. We also worked with the National Oncology Society because in Maryland, we are not allowed to participate in the one value-based program that is national for oncology, which I think some of the oncologists probably appreciate that we're not able to participate in it, but nonetheless, we aren't allowed to because of the unique total cost of care. It's excluded. So we had multiple meetings and tried to find a way to fit oncology in because it desperately needs to be done. But the complexity around the drug costs, and again, Mr. Doran probably knows a lot about this from his time at Anne Arundel. The drug costs budget can be blown up under the waiver in 6 months of a hospital, in 2 months in some cases. So it's very difficult because a new drug could come on or something could happen. We've not been able to figure out how to deal with that issue based on our inability to deal with the drug cost issue that I mentioned earlier. So we are working on that. If you want Dr. Bandari, I'm very happy to connect you with Dr. Solano if we have a new way to do it or a better idea. This is one that is a high priority. We'd like to do it. I think CMMI would love us to figure it out, and I think it's a great question. With regards to orthopedics is in EQIP on the first one. I think the reason that we didn't have a lot of people take up orthopedics is the nature of the concentration of that market. Almost 25% of the orthopedics folks are tied up in a large private practice aggregator, and they are all participating in EQIP, and they are participating in value-based contracts with multiple payers. So I think because they were so advanced and were already in it, they didn't take advantage of the grant, and that makes sense. The head of that aggregation, the head physician, Dr. Grasso, is also on the EQIP committee, and we are working closely with him and several other physicians from some of the systems. And I'm not remembering which physicians, but I know Peninsula has been involved, or I'm sorry, Title Health has been involved, and so is Johns Hopkins, particularly Johns Hopkins. We are looking at adding additional bundles to EQIP in future years. It might make sense, and maybe Will Daniels and myself or somebody else could come back and give you a full presentation on EQIP. I think it's really neat. I think the fact that we had over 1,000 physicians sign up for a new value-based program for specialists in Maryland starting in January 1 of 23, which is the first operational year, is pretty huge. I mean, as a percentage for those 3 specialists, we're talking about a very large percentage of physicians. And I think it's a neat thing that we're working on. And if you want to learn more about it, we could do a more detailed report. Or if any of you want, I can certainly send you some of the videos or some other slides that we've done around EQIP.
Thank you so much. We appreciate it.
Thank you, Dr. Bandari. Good to see you.
Any other questions? I have one, Mr. Ransom. One of the most exciting things to me, just looking at practice transformation, is data is addictive. I mean, I'll give the example of I would be outraged if you told me I had to drive to Washington now and I wouldn't know what the traffic is on 495 now leaving the house. Whereas in the old days, you would just sail off and hope that it was got there, right? Like as you get. My question is for for the practices as they transform, people think of it as stop doing things that causes cost. And that's not really, to me, what it's about. And I'm just wondering if you're seeing anything with the doctors, that same sense of, I can see more, I see a bigger field. I'm getting used now to integrating different things and coming to better outcomes.
I would say with regards to the transformation grant, we're probably a little early to start seeing that. I'm hoping we're going to see that. With regards to, now we've had a CTO, and in fact, my staff tells me never to call it this, but I often call it the CTO of last resort because we'll take anybody. And it doesn't matter, we're not, some of the other CTOs are a little more restrictive, they don't want, we will take someone who has, just got an EMR, doesn't have any skills. We have really seen some of those practices transform. We have had practices who've been in our CTO and really started at the first level with no skill and gone to now they're able to do the program themselves totally independently. They've integrated behavioral health. They've done things that they would never consider doing, which ends up with a better level of care. So I'm hoping that with this grant, we'll see the same thing. And I think once we start the modules, which will be happening very soon, now that we've done the assessments, we're going to start to see that where they're going to say, wait a second, if I use my staff a little differently, if I redesign things, I can be more efficient and I can work on the higher level stuff and I can provide the patient a better level of care. So I'm hoping I'll be able to come back to you in 6 months and say,
no, I was giving it to you. I was giving it to you.
I think
Someone should put their phone on mute.
Thank you. All right. Any other questions?
Thank
What y'all doing?
Mr. Ransom, for the comments. Who else is talking if they could?
Oh, you're not doing right because everybody following you, Jayla. You should have told them.
But I think, I want to reemphasize how important the program is. You look at some of the CMMI maps of where models are.
Okay, but y'all gotta be more.
You would see none in Maryland except for the total cost of care. We have to develop our own, basically based on our own energy. We've had a primary care model. We've had some ACO models, but the EQUIP program is really the first one that's aimed at specialists. And Dr. Bandari made the good point that it's not everyone, but it's an important start and it's a foundation to really engage specialists more fully in the total cost of care model in a way that they can deliver higher quality, efficient care, but also can benefit themselves. So I think it's a foundational piece of the model. And it's great to see not only is Care First using Prometheus, EQUIP using Prometheus, but the Healthcare Commission's longstanding, where the cost initiative is also using Prometheus as a transparency tool. So we're getting some alignment. Obviously, we'd like to see consumers shopping more for healthcare, but even in the absence of that, because provider groups being able to see where they stand in a public site, I think is helpful too. So thank you very much, Melanie and Mr. Ransom. Great presentation.
Thank you. Thanks for having me.
Agenda item number 9, presentation on nursing home family experience of care survey results. Maryland is one of the few states that administers an annual nursing home experience of care survey designed to objectively assess consumer satisfaction with nursing homes across the state. The 2021 survey process is complete. Stacey Howes, Chief for the Long-Term Care and Health Plans Quality Initiative, will summarize the survey results. Stacey, please proceed.
Good afternoon, Mr. Chairman, Commissioners. Today we'll provide a brief update on nursing home acquisitions. With increases in the acquisitions of nursing homes, there have been recent discussions with the Commissioners regarding the need for oversight, both on the federal and state level. Many of these efforts seek to increase the transparency of the transactions. Next slide, please. And next slide. Thank you. Due to concerns about the quality of care in nursing homes, often exacerbated by the COVID pandemic, there have been several recent federal initiatives. These include a MedPAC report to Congress last year. Also, the General Accounting Office was directed to conduct a study of private equity investments in healthcare overall, and the results are due by the fall of this year. Although this presentation focuses on nursing homes, it should be noted that private equity acquisitions are occurring throughout the healthcare system, from hospitals and ambulatory care centers to physician practices. In addition, CMS has developed a database including changes in nursing home ownership from 2016 to the present. This should enhance our ability to gain access to information on national chains and facility operations in other states. Still, another initiative is to dive deeper into the levels of corporate ownership. These involve multiple layers and are often far from transparent. In cases of change of ownership, CMS has now recommended moving the target of civil money penalties from nursing home administrators to nursing home owners when the facility has closed. This should help to address financial responsibility. Next slide, please. As I mentioned, the focus of many of these studies is on private equity ownership. This is defined by MedPAC in this slide. Although most nursing home ownership is for-profit, private equity is a small subgroup. MedPAC estimated this to be about 4% of hospitals and about 11% of nursing homes. As the MedPAC study discusses, there are advantages and disadvantages to private equity ownership, and the research findings are mixed. Proponents argue that private equity firms improve the performance of the companies they acquire, generate better returns, and provide needed capital for facility improvements. Those who oppose private equity involvement argue that private equity firms can weaken the long-term health of the companies they acquire by weighing them down with debt, increase costs using market power to obtain higher payment rates, and have incentive to cut costs by reducing staffing and patient care. Next slide, please. The most frequently cited research is based on a study done by Cornell University researchers as reported in the Journal of the American Medical Association, or JAMA. I realize this is difficult to read, but basically the table focuses on 3 outcome measures, 2 quality and 1 cost. Focusing on the last column, it shows that private equity firm acquisition was associated with an 11% relative increase in ambulatory care sensitive, that is preventable, emergency department visits, an 8.7% increase in preventable hospitalizations, and a 3.9% relative increase in total quarterly costs. Next slide. The overall conclusions from the study are shown in this slide. The study shows that private equity firms provided lower quality using common preventable measures at higher costs to Medicare. Next slide. I would like to now move from federal initiatives to what is happening regarding oversight of nursing home acquisitions in Maryland. The State Licensing and Certification Agency, the Office of Healthcare Quality, or OHCQ, has the authority in its licensing regulations to impose civil money penalties based on the history and severity of deficiencies. This does not relate specifically to change in ownership, but rather illustrates the broad authority of OHCQ beyond licensing and was also discussed as a target under federal initiatives. In addition, OHCQ now requires far more detailed information from facilities involved with a nursing home change of ownership, or CHOW. Some of the types of forms and statements required are listed on the slide, including detailed provider ownership, evidence of financial ability to operate, and adverse legal actions or convictions. OHCQ has also established a CHOW dashboard where links to all of these documents are available. Next slide, please. Under its regulations, OHCQ, as well as CMS, the Office of the Inspector General, can collect civil money penalties. These funds in Maryland go into a healthcare quality account, which provides grants to fund various education and quality initiatives, including caregiver training programs for specific populations, technology for telehealth visits during the pandemic, and in-person visitation aid to assist facilities in reopening. Next slide, please. The role of the commission regarding nursing home acquisitions is more narrow. Although the commission has detailed oversight for review of CON applications, the authority for review of acquisitions is far more limited. The procedural regulations for determination of non-coverage under COMAR 1024-0103 basically require notification to the commission 30 days prior to closing on the acquisition. Specific information requested includes healthcare services, bed capacity, admissions, gross operating revenue, and any other information required by the service-specific chapter of the state health plan. Next slide, please. The last item is key. Since this specifies that the service-specific chapter of the state health plan can impose additional requirements, the nursing home chapter, COMAR 1024-20, in this most recent update, added several items to collect more detailed information. These include the identity of each person with an ownership interest in acquiring entity, the percentage of ownership interest, history of each person's experience in ownership or operation of healthcare facilities, affirmation that the services will not change, affirmation of commitment to Medicaid participation, also corporate structure and affiliations of the purchaser, the purchase price and the source of funds, and a report on the number and percentage of nursing home beds in the jurisdiction and region controlled before and after the acquisition. Next slide. In addition, another important component of the nursing home chapter is the affirmation shown on this slide. Affirmation under penalties of perjury that within the last 10 years, no owner, former owner, or member of senior management, and it goes on to other levels of management, has been convicted of a felony or crime or pleaded guilty, and again, more levels of pleading, and that the applicant or related or affiliated entity has not paid a civil penalty in excess of $10 million that relates to the ownership or management of a healthcare facility. We also added that the existence of any of these factors would be a specific disqualification which would permit the commission to deny the acquisition. Next slide. Information on CHOWs is collected as part of our long-term care survey. Thanks to Catherine Victorine for collecting and reporting this data. Recent information is shown here, and you can see it ranges from 17 to 22 CHOWs recently. As a comparison, in 2016, there were only 5 CHOWs, and in 2015, only 6. Next slide. Finally, as you know, we have increased the details of reporting on nursing home acquisitions in your monthly commission update. Thanks to Jean Marie Gowell for researching and reporting this data. In addition to what I mentioned, nursing home chapter requires, we have also been checking on levels of ownership, years the facility was owned, star ratings, multiple bedrooms, and CMS citations as special focus facility. This is all part of an effort to increase transparency in these transactions. Next slide. Next steps include continuing to monitor developments on the national and local level, monitoring legislative proposals, as well as to update our regulations and reporting as needed. That concludes my presentation. I'd be happy to answer any questions.
I should first start off by apologizing that I read the wrong intro for the agenda item. Sorry, Linda, I will promise never to call you Stacy again. This is, of course, Linda Cole, Chief of Long-Term Care Policy and Planning. This sort of thing would never have happened under Chair Pollack. It is an important topic, though. So there are folks who have any commissioners with questions?
I'm just curious, what happens with this report? I mean, we accept it or we approve it or?
It doesn't require action. This is for information. It was an update to just for information.
Does it stay with us or do we disseminate it to somebody else? What do we do with this?
So this is a presentation, I wouldn't say it's a report, but it highlights issues that are of general interest. It's been shared previously with the the leadership of the two associations. And
The
with,
nursing home associations that were here.
yes, that, yes,
Okay.
that were here 2 or 3 months ago,
Right.
as well as colleagues in the Department of Health, as well as another former nursing home owner who attended the meeting. I haven't gotten any specific questions about this, but it's clearly after this meeting, I would say our plans are to share it with some of the elected leaders, the elected members that have shown interest in this area and introduced bills over the last 2 years, give them a picture of what's happening.
Based on really great information, are we recommending, are we doing something different, or does it just sit for a year, or, I mean?
Well, I think,
What happens
yeah,
with
I mean, I
something,
think,
all the work, and then I'm always curious, what do we do with it?
so there were a number of bills focusing on long-term care, a couple
Right.
passed, but the one specifically requiring the Healthcare Commission to report on financial performance of organization of nursing homes using the Medicaid cost report failed. I think that will likely reappear. We could contemplate additional legislation this next session. As Linda has noted, our authority is pretty limited, and the vehicle through which nursing home industry is changing today is not through applicants coming in and asking for CONs. It's through acquisitions. I think we all have to be mindful of that, since that's the vehicle and that's the area which we have pretty limited authority. As Linda noted, it's primarily
information.
Yeah, commitments on the part of applicants. We have some evidence that acquirers pay attention to those in the way that they position owners, but not done a systematic review to look at people who've walked away from this purchase. But I think it's up to the commission to decide if there's additional scope that we would like in our regulations beyond what authorities we have today. As noted, acquisitions are the vehicle through which the system is changing and new entrants are entering the state. And we could determine if we wanted to change the statute to give us greater authority over those acquisitions.
And if we do, you'll come back to us with recommendations. Is that what happened?
Mr. Chairman.
Somebody had a question?
That was Commissioner Metz.
So Commissioner Metz, and I see you, Commissioner Boyle, you're on deck. Commissioner Metz.
Yeah, of course, this is what I do for 29 years. Yeah, the legislation that was introduced, most of that data, if not almost all of that data, is already obtainable. We already have it, through payroll-based journal reporting, cost reporting, et cetera. A lot of it would have been redundant. I know there's an effort to examine the financial status of corporations running facilities. Incredibly difficult to do because they're set up and layered such that the larger organizations don't want you to see what they're doing. And it's almost impossible to determine accurately their financial status. With that being said, how this was driven and where it's been driven from, we've had quite a number of acquisitions, as the commission knows, over the last several years, with prices per bed increasing exponentially up to as much or in excess of $200,000 a bed, which is an incredible price. So you're seeing 100-bed facilities being purchased for as much as $20 million, which I run a smaller facility with 66 beds. We're locally owned. I have a couple partners. We're not part of a corporation with 16 assisted living beds. And so the reason legislators have become involved is, Mr. and Mrs. Jane Doe down the street saw their traditionally very nice nursing facility acquired, and the quality of that facility diminish quite a bit. And they're wondering what's going on. And of course, people reach out to their legislators. It's not easy to reach out to OHCQ per se, or to the commission. So they call their senator or delegate, who in turn then gets themselves involved. We see it. I see it here where my facility has a pretty good waiting list. We're a 5-star facility, so we've had that, but it's more so now than ever. Quite a few facilities have entered the market from the New York, New Jersey area. Not disparaging them. There's some very good groups there as well. The reason Maryland is such a attractive target is twofold. One, Maryland has pretty good Medicaid payer rates as opposed to other American states. However, probably the biggest reason is Maryland has the lowest penetration of managed Medicare in the nation. So it's attractive for facilities to acquire facilities in Maryland because they believe, either justifiably so or otherwise, that they can maximize revenue through the traditional Medicare model instead of a managed, an advantage plan or a managed Medicare model. And that's what's kind of got us to where we are today. There's concern, and I know the associations have dealt with it. The commission's heard from elected representatives, et cetera, on ways to strengthen the application process or the transfer process so that there's more continuity and also more transparency when a change like that takes place. But when mortgages triple or quadruple from what they were after they're acquired, that results in the facilities looking very closely, maybe too closely, at their cost, cuts across the board in different areas, staffing being reduced to minimum levels, and maximization of that Medicare revenue. That's it in a nutshell. That's what's going on. So it's not everybody. There's lots of good out-of-state providers and corporations buying facilities in Maryland, but there's some that aren't. So I hope that gives some insight.
Thank you, Commissioner Met. Commissioner Boyle, did you have a question or a comment?
I had two questions, but one, I'd like to follow up with Commissioner Metz. Given what you just laid out, do you have what would be your recommendations that the state could do to ensure that reducing the quality of service doesn't happen?
Well, there's lots of mechanisms in place with the Office of Healthcare Quality, with the survey process, et cetera, with all the heartburn that I have over the years and some of the subjectivity with that. It is an ongoing mechanism for such. I do think that there are ways to possibly, and I think the association supported in strengthening that application process, where pro forma financial statements, et cetera, can show how somebody can reasonably expect to pay such a large mortgage and how it's going to impact their quality of care going forward in each of their respective cost centers. There's only so much money in a pool. There's only so much that you can see averages, top end averages below. You need to see the top outliers and the bottom side to see where facilities in Maryland come in at with their cost reports. The data is there. It's just a matter of pulling that data together to see what the best approach would be, or if there's some average amount, where we see at the top end where if so much a bed is being paid, we see that they're not going to be able, a facility is not going to be able to, based on historicals, have a strong bottom line or good quality of care. But that becomes challenging with what I said earlier, where larger corporations they're layered in such that not to say that they're masking their operations, but you have a realco, you have a management company, you may have multiple management companies or multiple realcos in place. Sometimes difficult for even the owners to follow without their accountants. It's a challenging thing, and it's come to Maryland, and that's why we're hearing about it. That's why we're hearing about it now. I know the next thing we're going to talk about is the performance of facilities based on family satisfaction surveys, which I think is an excellent tool. We use it quite a bit to gauge how well we're doing. It may even be more beneficial than the survey process because the consumer themselves are giving us input. But I don't have all the answers on it, but I'm sure that's something that the commission is going and the legislature is going to address going forward if the quality of care at our facilities continues to be impacted.
Thank you. I just one other point, it may not, I don't know if it would be helpful or not, but in the slide about COMAR 10-2420, that they have to indicate that they have not paid a civil penalty in excess of $10 million. Would it be helpful at all to lower that amount? Are we missing a lot, or is $10 million considered appropriate? It seems high to me.
I mean, it depends upon the size of the facility and what's going on. I mean, I've only had one civil money penalty in the history of our facility, and I would argue that went to my grave. That was implemented unjustly. Some civil money penalties are being implemented correctly. There is some subjectivity in the survey process. There was a peer article come out, and I can't put my fingers on it right now, regarding how facilities are funded, how facilities are surveyed, et cetera, on how we do our business, and it's not just a simple answer of are we penalizing people too much. Penalties are meant to motivate folks to do better. Many times all they do is just take very badly needed funding from facilities. One of the first things that happen, and people are unaware of this, we have such shortages in staffing, especially post-pandemic, with nursing and nursing assistants, et cetera. In the nursing assistant area, one of the first things that CMS and OHCQ are mandated to do with a poor survey is take a facilities nurse aid training program. What good does that do? I mean, it does no good at all. All it does is take the mechanism away for a facility to train and hire GNAs, which we need, greatly. So I could go on all day with the challenges in the good parts and the bad parts in long-term care.
Thank you, Commissioner Metz and Commissioner Boyle. Are there any other questions or comments? Not hearing anything. Thank you, Linda.
Thank you.
And I think it's an important issue to keep our eye on what we appropriately should do in that area, and as well as what we could do. With that, we really will go to the nursing home family experience of care survey results.
Good afternoon, commissioners. Next slide, please.
And just to refresh everybody, I already introduced Stacy Howe a little early, but she's our chief for the long-term care and health plans quality initiative.
Thank you. So there's quite a bit of evidence that shows that people want data on consumer satisfaction in nursing homes, and satisfaction has been shown to represent a unique dimension of quality. Also, families and residents want to contribute to and benefit from satisfaction surveys. I think it's also important to note that MHCC is required to develop and implement a system to comparatively evaluate the quality of care and performance of nursing facilities. And this survey is a response to that requirement. Maryland is one of only 4 states to mandate a satisfaction survey. The other 3 are Rhode Island, Minnesota, and Ohio. Rhode Island's scores had been decreasing over the last few years. Minnesota's had been increasing, but then decreased in 2019. And Ohio's had been remaining fairly steady. None of these states did a survey in 2020, but they all did it in 2021. Unfortunately, none of them will have their data available until summer, so I can't share that with you just yet. Also, I want to point out that the survey has been shown to be reliable and valid based on traditional statistical and research criteria. I'm not going to go over those numbers and criteria, but if you're interested in the details, I've included them in an appendix at the end of this presentation. Next slide, please. So a little background on the survey. It's designed to elicit levels of satisfaction with a loved one's care in nursing homes. We only look at long-stay residents. And we send our survey to responsible parties. It's usually a loved one or a family member, but sometimes it's a friend or a neighbor. And then the results are used to evaluate the quality of care and performance of Maryland nursing homes. And what we do is we take the data and we present it in a consumer-friendly way on our Maryland quality reporting site. And the scores are also one factor in the pay for performance program, Medicaid pay for performance program, and one factor in some of the MHCC CON reviews. Next slide, please. We've been conducting this survey for quite a few years now. It was first piloted in 2005, and then the first full administration was in 2007, and it's been administered almost yearly ever since. Next slide, please. We've also taken many steps to enhance the survey over the last few years. We did an analysis to see if we could identify any gaps in the information we were gathering, and we added 13 questions to address those gaps. We started offering a Spanish language option, an online option, and a phone interview option. We also last year introduced 3 COVID satisfaction questions. That's satisfaction to the COVID response. And we also added an open-ended question. Next slide, please. So this year, all 222 nursing homes responded to the survey. Participated in the survey. And of the people that we sent the survey to, we had a 32% response rate. That's a bit down from previous years, but 32% is still considered in the acceptable range. Next slide, please. We take all of the data and we tabulate it into 7 different domains, which I've listed here on the screen. So they are the staff and administration, care provided to residents, food and meals, autonomy and resident rights, the physical aspects of the nursing home, activities, and security and residents' personal rights. Next slide, please. We also calculate 2 overall measures of satisfaction. So we calculate the overall rating of care received and the percent who definitely would or probably would recommend that nursing home. And then we also have the one open-ended question where we simply ask, what else would you like to share with us? Next slide, please. And then we ask 3 questions about the COVID response. And they allow us to calculate the percentage who said that the staff of the nursing home always or usually kept them informed of how the COVID outbreak affected their loved one. Received at the nursing home in response to the outbreak. Oh. Next slide, please. Did you hear all of that? I think I froze for a minute.
You did.
Okay, can you go back to the last slide? What was this where I lost you? Okay, so we are able to calculate the percentage who said that staff of the nursing home always or usually kept informed of how the outbreak affected their loved one, the percentage who said staff of the nursing home always or usually kept them involved in the residents' care decisions, and then the overall rating of care received at the nursing home in response to the COVID outbreak. Next slide, please. We also take all of the data and we divide it into peer groups. And the 4 peer groups are the region of the state, the size of the nursing home, the ownership type, and the payment source. Next slide, please. So these are the overall results for the 2021 administration. The first 7 rows are the 7 domains I went over just a minute ago. Those are all scored on a scale of 1 to 4, with 4 being the best score. And you can see that 6 of the 7 are 3 or higher. There's only 1 that fell below a 3, and that's activities at a 2.6. This is not a terribly surprising score because activities is the domain where we ask questions such as, are meaningful activities offered at the nursing home? And a lot of these have been canceled over the past few years because of COVID. So it's not surprising that the score went down a bit. The second to last row is the overall rating of care, and that's on a scale of 1 to 10, where 10 is the best score. And the score this year is 7.5, which I would consider in the okay range. And then 75% said that they definitely would or probably would recommend the nursing home. Again, I would put this in the okay range. Next slide, please. We're also able to trend the data over the last few years. This is 3 of the 7 domains. The blue bar, the dark blue bar, is the 2021 score. And for all 3 of these domains, the 2021 score is statistically significantly lower than the 2020 score. Next slide, please. These are the remaining 4 domains, and the 2 domains represented on the right side of the graph are the 2021 score is statistically significantly lower than the 2020 score. And then the 2 domains on the left side of the graph, the score for 2021 is pretty consistent with the last few years. Next slide, please. And then the score of 7.5, which was the overall satisfaction with the nursing home, that score is statistically significantly lower than 2020. And the 75% who would recommend the nursing home, that score is also statistically significantly lower than the 2020 score. Next slide, please. These are the peer group comparisons. For all 7 domains, the overall rating and the percent who would recommend the nursing home, the state score was significantly lower than nursing homes in Western Maryland, small nursing homes, homes with 81 to 120 beds, and not-for-profit homes. So what this means is that nursing homes that fall into the categories on the right side in red are performing better than the state average. And the state score was significantly higher than homes in Southern Maryland, larger homes, and for-profit homes. And what that means is that the homes in the categories on the right side in blue are performing worse than the state average. And all of these findings have been fairly consistent over the last few years. Next slide, please. These are the results of the open-ended question where people could just write in what was on their mind. And of the people who responded to the survey, approximately half wrote something in for this question. These are the top responses. So you can see that the very first top response is that they were unable to visit and it was hard to answer the question. So that's a bit of a neutral response. The next 3 are negative, but then the next 3 are positive. So there's a mixture of responses. Next slide, please. So these are the results for the 3 questions that we asked about COVID. I apologize, but the numbers for 2021 were entered incorrectly onto the slide. The 2020 numbers are correct. So what we found is that 80% always or usually received timely information about how residents were affected by the outbreak in 2021. So that's just a little bit less than last year's score. And then 75% said that staff always or usually involved loved ones in, staff always or usually involve them in their loved one's care. So that's quite a bit lower than last year. And 78% rated the nursing home response to the outbreak as a 7 or higher, so a little bit lower than last year's findings. Next slide, please. So these are the statewide numbers on the first row are correct on this slide. And these are the same numbers that should be reflected on the previous slide. So these are the COVID responses, and I've broken them down by peer group so that you can see a certain pattern. So if you look at these numbers, you'll see that the highest scores are in Western Maryland, smaller nursing homes, which is less than or equal to 80 beds, and not-for-profit homes. So this is the exact same pattern as the overall state results for the larger survey. So next slide, please. We also looked at COVID infections and how they were associated to satisfaction. So we found that staff COVID cases were significantly associated with higher overall satisfaction with care and higher overall satisfaction with the nursing home's response to the COVID outbreak. We did not find that resident cases were significantly associated with our satisfaction measures. Next slide, please. We also looked at whether or not our satisfaction measures were associated with the CMS stars. So on the left-hand side of this table are our 7 domains, the 2 individual measures, and the 3 COVID questions. And so what this shows is that all of our satisfaction measures are statistically significantly and positively correlated with the overall star, the health inspection star, and the staffing star. What that means is that as the scores on our satisfaction measures go up, the stars go up. And the opposite is also true. As the scores on our satisfaction measures go down, the stars go down. Next slide, please. We also examined some health disparities. We wanted to know if there were differences in satisfaction by race, payment source, or ownership type. And we found that whites were more satisfied than non-whites. Those in not-for-profit homes were more satisfied than those in for-profit homes. And those with Medicaid were more satisfied than those with another type of insurance. And because you probably noticed that I said earlier that larger nursing homes tend to be, people in larger nursing homes tend to be less satisfied than those in smaller nursing homes, but it's also quite intertwined with whether or not you're on Medicaid. So we wanted to tease that apart a bit. And what we found is that those in large, so we narrowed down our sample and we took out all of the small nursing homes and only looked at the large nursing homes. And what we found is that those in larger nursing homes with Medicaid were significantly more satisfied than those in larger nursing homes with other types of insurance. Next slide, please. And because Linda Cole was just talking about nursing home acquisitions, we wanted to see if nursing home acquisitions were associated with satisfaction. And so we categorized nursing homes into 3 groups: 0 acquisitions, 1 acquisition, or 2 or more acquisitions. And then all of these acquisitions took place in 2015 to 17. And you can see that all nursing homes have decreased in satisfaction over the last year, that past 8 years. But the dark blue line represents homes with 0 acquisitions. And you can see they are statistically significantly more satisfied at every single time point compared to homes with any number of satisfaction acquisitions. Next slide, please. We repeated the analysis, but this time instead of number of acquisitions, we looked at type of acquisition. So no acquisitions, operator only, or property change only. And it's pretty much the same pattern. Those with no acquisitions were statistically significantly more satisfied at all times. Next slide, please. So in conclusion, the decline in satisfaction that we've seen over the past few years has continued this year after brief stabilization in 2020. And then the results mostly indicate a good level of satisfaction in several categories statewide, though there are a few that are now dipping into the okay category. Also, the results indicate a bit of a decline in level of satisfaction in the COVID response. And we are looking at multiple ideas to help nursing homes improve. One of those is that we are trying to create incentives to recognize those who consistently perform well and also recognize those who improve significantly over a period of time. We also are trying to put together a webinar to invite high performers to assist low performers. Next slide, please. So we're engaging in quite a bit of outreach in our center. We are reaching out to industry by, one is the Department of Aging, who we've developed a great relationship with over the past year. We also share all of our data with nursing homes, both on our website and in report form. We are also reaching out to the community by making sure our data is on our website in a consumer-friendly way. We also want to encourage as many people as possible to fill out our survey. So we began offering multiple ways to fill it out and also offering it in Spanish. And we've also, as I just mentioned, we're creating a program to identify top performers. And the point of that is to help people pick the best nursing home for them. We also spend time integrating data sources to inform our understanding of patterns and any data changes, and also to identify areas of potential improvement. We're also making sure that we have a major social media presence, and we've engaged in print, TV, and digital ads. You may have seen some of them over the past 6 months. And we also have a significant number of printed materials that we share with both consumers and the industry. And we've also started giving educational webinars to those in the industry who may want to learn how to use our website in the best way possible for their needs. Next slide, please. Before I finish, I just want to thank Julie Duffy, my colleague, for all her help on this project, and also Market Decisions for their work as the contractor on this survey.
Thank you. Are there any questions? I see Commissioner Boyle has her hand up.
Yeah, I'm just curious, are caregivers of deceased patients in the last year, obviously, surveyed?
Yes, we include anybody who lived there. We define a time period. So anyone that lived in the nursing home during a specific 6 months, their loved one is included, even if the person passed away during that same time period. And
how many? That's good to know. How many respond? What percentage response? Do you have any idea?
Of those who passed away?
Yeah.
No, I don't know that. That's a good question. I wonder if I can figure that out. If I do have the data to figure that out, I can report back.
Okay, great. Thanks.
Are there any other questions? I had one for you. If you look at the acquisitions and satisfaction, the difference between not-for-profit and for-profit homes was about 1 point. And the difference between the acquisitions and no acquisitions is about 1 point. And I'm wondering, it seems to me that for-profit homes, which would be 1 point lower on average, are more likely to be acquired than not-for-profit homes. Is there sort of are those really two different lines on acquisitions, or do we have something going on between all the for-profits in one category, more of them, than in the other?
Can we go back a couple of slides? Another one.
Everybody's probably wondering what the heck I'm talking about.
Are you talking about this one?
That one or the previous one, either one.
These are not divided by for-profit and not for-profit.
Yeah, that was sort of my question, is the for-profit ones would automatically start with a lower average. So if it was mostly for-profits that were in the acquisitions, you would expect them to be at a lower level of satisfaction independent of the acquisition, I guess was mine.
That's a good hypothesis. I think that's something I can look into.
It'll be interesting to note if we've got a distinction there that's sort of making a gap look bigger than it is.
Okay, I can definitely look into that.
So this information at the facility level is going to be on our quality performance website. How quickly, Stacy, can you give us, the commissioners, an indication of that? I think obviously the summary report for an individual family member or someone considering a nursing home isn't as important as the facility level results and the ability to compare those results across several
Yes.
homes.
Yes, I have all of the facility level data and it's being formatted as we speak. So it should be on the website within just a couple of weeks so that families can use it.
I don't mean by my questions to hold up that process. Well, thank you very much.
Thank you.
We have a final agenda item. Spending and use among Maryland's privately insured 2020 data. The Maryland Healthcare Commission is required under its statute to report annually on spending for privately insured services using the Maryland Medical Care Database. This report examines the Maryland privately insured population's healthcare spending and use, and reports on enrollment trends, population risk, cost, and utilization indicators to inform policymaking. The analysis used 2018, 2019, and 2020 data and contains insurance enrollment data and healthcare claims data for Maryland residents. Shankar Mehta, Chief of Cost and Analysis, Center of Analysis and Information Systems, will give us this update. Shankar, you have the floor.
Thank you, Mr. Chairman. Good afternoon, Commissioners. Thank you for sharing the purpose of my presentation. I am pleased to present this annual report once again on behalf of my division today. This report, as Mr. Chairman mentioned, focuses on 2020 MCDB data during which the COVID-19 pandemic affected the entire world. In addition to the spending and use, I'll also share a snapshot of COVID-19 members and telehealth visits trend among the study population. Next slide, please. Thank you. So I want to put some context to this report. This report serves as an annual checkup on the privately insured population to better understand the healthcare spending and use in Maryland, and then compare to the national benchmark to gain insights to inform policymaking. It also helps us, the data users, to determine the representativeness of MCDB for research purposes. So each year, the Commission staff analyzes the most recent 3 years of data in MCDB to report on enrollment trends, population risk, cost and utilization of healthcare services among members enrolled in private insurance. This report contains data about Maryland residents enrolled in fully insured, self-insured health plans, and who are under 65 years of age. We excluded self-insured ERISA and federal employees' health benefit members' data from this report. This exclusion accounts for about 44% or 1.68 million members. As previously noted, the study conducted by HSCRC using the 2019 MCDB data and hospital discharge data found that for patients using the hospital services, the case mix index and the age distribution are similar for the subset of patients seen in the MCDB relative to the total population of patients observed in the hospital discharge data. This result means that despite excluding the self-insured ERISA and federal health employee benefit plans, the MCDB still represents the larger privately insured population for research and policy making. For this report, we had to recalculate 2018 and 2019 data because we used BTOS 2.0 classification to identify professional and lab imaging, which resulted in different growth rate for these two categories in 2019 than the previously reported growth rate in the prior year's report. Next slide, please. So overall, the per capita spending across all markets was $5,732 per person in 2020, increasing 2.2% compared to 2019. As per a recent study published in the JAMA Journal, researchers used the hospital data from January 2018 through July 2020, and it found that by the beginning of the second quarter of 2020, the total monthly inpatient revenue decreased by 17% and outpatient revenue decreased by 45.5% when they compared 2018 and 2019 revenues for the same period. So due to the intervention from HSCRC, the study found that by July 2020, inpatient revenues increased by 6.6% and outpatient revenue increased by 2.8% compared to 2018 and 2019 values. And this is one of the key reasons why we saw a positive growth rate in Maryland spending when we compare to other states, which show a decline. So when we compare the MCDB data to the CMS National Health Expenditure 2020 report, it showed that among private health insurance, the per person spending was approximately about $5,759, which is an increase of about 2.6% after we exclude the Medigap, the dental services, and the net cost of private insurance, so that we can make apples to apple comparison between the National Health Expenditure data and MCDB data. So the next chart, so within each market type, we observed different growth rates. The large group showed a growth rate of 2.6%. The small group increased by about 1%, and the individual market showed a decrease of 3.7%. Next slide, please. So in 2020, there were about 1.35 million members under 65 years of age enrolled across all markets at the end of December. These members were about the same when we compare to the prior year. Enrollment in small employers showed a decline of 5.2%. Overall enrollment in the individual market increased by almost 22% in 2020. So enrollment in the on-exchange market grew by about 19%. In 2020, the Maryland Health Benefit Exchange launched an easy enrollment program and special enrollment period in response to the pandemic. Due to the financial burden impact of the COVID-19, individuals who lost employer-sponsored insurance enrolled in either Medicaid or the individual market, which led to the significant growth in individual market during 2020. The State Health Access Data Assistance Center showed that enrollment among privately insured in Maryland increased by 2% in 2020. And SHADAC also reported that uninsured members decreased by 27% in 2020 due to the special enrollment initiatives in response to the pandemic. So now let me show you the illness burden and the chronic conditions prevalence in the study population. Next slide, please. Okay, so we used the ACG grouper to calculate the illness burden. So overall, the mean ACG risk score decreased marginally across all market segments. The mean ACG risk score was consistently higher in the individual market, followed by the large group market and the small employer group market, indicating that the individual market had the highest illness burden. So this increased illness burden in the individual market is due to migration of the Maryland Health Insurance Plan high-risk pool members in the individual market. For chronic condition, we focused on diabetes, hypertension, asthma, and obesity for this report. All four chronic condition prevalence remained stable from 2019 to 2020. Hypertension remains the highest prevalence, and asthma had the lowest prevalence in 2020. Diabetes in particular is the Maryland Total Cost of Care model's priority area for improving population health. So next, we will look at the member spend within each type service type category for the from 2018 to 2020. Next slide, please. So to better understand the impact of the different service type on the overall total spending, we group the claims as inpatient, outpatient hospital, professional, lab and imaging, and prescription drugs. So our analysis showed that inpatient, professional services, and prescription drug expenditure per member increased during 2020. And these three service types were the primary contributors to the overall 2.2% increase in 2020. The other two categories, the hospital, outpatient hospital, and lab and imaging expenditures declined in 2020. In 2020, the inpatient hospital facility spending increased by 3.5%, which accounted for about 15% of the relative split of total privately insured per member spending. Outpatient services spending decreased by 4.7%, while professional service spending increased by 4.8%. Labs and imaging showed a decrease of 13%, which accounted for about 6% of the overall per member spending. Prescription drugs per member spending increased by about 7.2% growth, which accounted for 30% of the relative split of total expenditures. The second chart talks about the out-of-pocket spending, and we know that members are more concerned about their out-of-pocket share, which determines the affordability of healthcare services. So in 2020, the overall out-of-pocket spending for medical and pharmacy services was $676 per person, which was about 12% of the total per capita spending. The medical and pharmacy services contributed to 79% and 21% of the out-of-pocket expenditures. The out-of-pocket medical expenses decreased by about 12%, and pharmacy out-of-pocket spending remained flat when we compare to 2019. The 12% decrease in out-of-pocket spending was due to the impact of the pandemic, during which the utilization decreased and there was little cost sharing for COVID-19 testing and treatment. So now we will take a closer look at the drivers of this annual change. Next slide, please. So this slide will help us to understand what drove the increase or decrease within each category. So when we look at the inpatient facility cost, we see that it increased from $4,726 to $5,250, which was an 11.1% growth that contributed to the inpatient spending. The outpatient facility spending trend was driven by 14.2% decrease in utilization and 11.1% increase in unit cost. The increase in professional service per capita spending of about 4.8% was also primarily driven by the rise in utilization, which was about 3.2%, and the unit cost of 1.6%. The lab imaging spending, the trend was driven by 15% decrease in utilization and 2.8% increase in unit cost. The prescription drug per capita spending increased by 7.2%, which was primarily driven by the rise in unit cost of 5.9% and utilization of 1.3%. So the higher unit cost may in part reflect a changing mix of the services that was provided in 2020 during the pandemic. Next slide, please. To perform this analysis, we applied CDC guidelines for ICD-10 coding of COVID-19, and we found that there were about 51,037 patients with COVID diagnosis with a case rate of 378 per 10,000 enrollees. All patients who had the earliest claim for COVID-19 diagnosis from any healthcare setting were included in this analysis. Females had a slightly higher case rate than males. However, the studies have shown there is no gender difference in COVID-19 occurrence. A subset of COVID-19 study population was used to look at the inpatient hospitalization among the COVID-19 members. And our analysis found there were about 2,710 hospitalizations with the rate of 20 hospitalization for 10,000 enrollees, and 72% of the COVID-19 related hospitalization lasted for about 2 to 7 days. Next, we'll look at the telehealth utilization trend. Next slide, please. COVID-19 pandemic led to the temporary shutting down of many healthcare settings and a rapid switch to telehealth strategies. So we looked at trends in telehealth and non-telehealth visits for 2020. Before March 2020, telehealth claims grew at a prolonged rate. With the onset of the pandemic, we saw an abrupt spike in telehealth claims in spring 2020, reaching about 40% of total visits. And then it started to decline from summer 2020 onwards, which leveled off around approximately 20%. And to look at which type of visits drove the telehealth, we grouped the claims into relevant clinical body system, and we found that the mental health disorders were the leading diagnosis of telehealth visits before and during the pandemic. Next slide, please. So the key highlights from this year's report are that overall, the per capita spending across all markets was $5,732, increasing 2.2%. Prescription drugs, professional services, and inpatient services were the primary contributors to the overall 2.2% increase. The overall illness burden decreased marginally, and the overall enrollment as of December 31st was static in 2020. However, the enrollment in individual market increased by 22% due to the easy enrollment program and the special enrollment period to meet the immense need of the COVID-19 pandemic. In 2020, there were about 51,037 COVID cases and 2,710 COVID-19 hospitalizations in the privately insured claims data. And about 1 in 20 COVID-19 patients were hospitalized. And due to the COVID-19, there was an abrupt spike in the telehealth visits in the second quarter of 2020, followed by a gradual decline and leveling off. And mental health disorders were the leading diagnosis for the telehealth visits. So before I end, I would like to acknowledge the hard work of the contractors and the internal staff to bring this report to you. We're ready to take your questions. Thank you.
Thank you. Are there any questions? O'Connor?
Yes, thank you for your presentation. Very, very nice. A couple of questions. Did the rise of telehealth, did it drive up costs significantly? And the second question is the professional services, was that the cost of that, was that combination inpatient and outpatient care? You broke down the hospital inpatient, outpatient, but professional services, you didn't break down. Was that a combination inpatient, outpatient? I assume.
Sure. I will answer in two parts. The first part of the telehealth impact to the cost. We did not look into the cost related to the telehealth visit. Our focus was to look into the trends. But when we look into the kind of the overall kind of the growth rate in the professional, which is where most of the telehealth visits were found, we cannot say for sure what was the telehealth impact, but we can definitely look more closely on that and then look at what was the telehealth impact to the cost of the professional services. And the second part is in the profession.
I think it'd be nice to know that. So maybe we transform to a more telehealth type of, if it's cheaper and as effective.
Yeah, I think we're looking at that as part of the telehealth study. That's the $60,000 question. Is this telehealth?
We're only giving it 60,000. That's all.
Could you pay more? Is it a substitute? Is there a substitution effect, or is it additive in that a face-to-face visit also occurs? I think in the first several months of the pandemic, most people are finding that it was a substitution because most healthcare facilities were either completely closed down or limiting face-to-face visits. But I think as we move through the pandemic, there is some question about whether it becomes additive. So more to come on that from the work that we're doing in the telehealth study.
I think Commissioner O'Connor, it's a very interesting question because also a lot of providers may not have felt quite sure what to do with telehealth until the pandemic, and now they have a better grasp on it. It's like a new world to be studied anew starting today as to what the steady state will be.
Because I know what to do with it.
Well, I don't want to speak for the medical community. but I think they certainly have a better idea, right? So, any other questions? Comments? I had one, this comment, if on slide number 6, I believe. If you could show that one. That's it. If you look at this stack, the inpatient hospital facility at the bottom there is 15% of our spend. And if I understand that, that's pretty much what the HSCRC's regulated hospital fees and rates fall into. And that's half of our drug cost. So when we talk about the total cost of care and the initiatives that Mr. Ransom came to talk to us about, if you look at that stack, we're not going to be able to beat up on any one slice of that stack and solve the expense of healthcare. We really need a total patient approach that talks about how we manage drug spend and how we manage all the different layers in that stack. So I just thought that really struck me when I was looking at the presentation of how much sometimes we'll talk about something and we realize how little of the segment it really is any one individual component. With that, unless the commissioner. I'm sorry, Commissioner Bendard?
Chair Sergeant, that's what I was trying to say. There are other costs involved, as you mentioned, drug cost and the diagnostic costs. Those are very expensive, and oncology field is one of the most expensive.
Thank you.
Your point is very well taken. It's going to be a real challenge where we have to be very creative to bring down the total cost of care, especially in certain specialties like oncology. Same with the rheumatology. Their drugs are very expensive, and the patients, they need those drugs almost lifelong.
Thank you. And with that, we turn to agenda item 11, overview of upcoming activities. Executive Director Ben.
Yeah, thank you, Chairman Sargent. Job well done. Thank you for all the commissioners for sticking with what we knew was a lengthy agenda. For June, last week I did send out a communication talking about a orientation principally focusing on health planning and certificate of need that we're going to have beginning at 11 o'clock. This is an educational session. It will be available either virtually or in person. If you can get here in person, that's great. If your day dictates attending virtually, that will work too. But we think this is very important. I think some of the discussions we heard today as related to the priorities for health planning indicate a great deal of interest on the part of everyone. That session will go continue through lunch. We hadn't planned to have a working lunch, and then the normal commission meeting would begin at 1 o'clock. We have several CON issues. We hope to dispense with this issue with Tacoma Park and the status of their urgent care facility that was considered about a year and a half ago, and the system in Tacoma Park are working for a mutually acceptable resolution of that issue. We also have several other minor CON issues to bring before you. We'll have a couple presentations on the Maryland Primary Care Program, a process one related to adding a new member to the advisory commission. And we hope to have a final decision on the part of the Centers for Medicare and Medicaid Innovations on track 3 of our application that would roll in January of 2023. That the key part of that would be it would incorporate two-sided risk into the model. One, very likely this third track will parallel but not be identical to a program that's operating nationally called Primary Care First. I also would like to have Teresa's team talk about the most recent patient safety information from our friends at Leapfrog. The name escaped me for a moment. We have those results. They're not quite as strong as they were in the past several reports, and I think it'd be good to make sure the commission is aware of the performance on quality and patient safety from Leapfrog. Expect to add probably another item from our health planning group, but we'll have to wait until the session approaches to give you an update on that. But I think it'll be a good meeting, recognizing that we're going to start at 11 o'clock. We'll try to keep the regular meeting a little more manageable than today, but thank you all for your persistence, attendance, and good questions, Rob.
Thank you, Ben. With that, do I have a motion? We've gotten through our agenda, so do I have a motion to adjourn? No, Connor? Take a second from, looks like Commissioner Bandari. Thank you, everyone. Thank you for a good meeting.
Thank you.
Bye.
I need the address of that restaurant. What time is it supposed to be?